Today is being presented by the Southwest Pediatric Practice Transformation Network. We are basically one of the 29 Transforming Clinical Practice Initiative award winners, and we are 18 months into a 4-year project. And we're going to talk just briefly about that. But thanks to all of you and many who couldn't be here today, we are, I believe, probably one of the highest performing practice transformation networks in the project. So very pleased. We're the only pure pediatric project of the 29 awardees. And consequently, we've had a lot of people calling us for information. So this morning I wanted to, you'll see both myself and Dominique Kinsler pop up and down today to introduce speakers. And I really want to recognize Dominique for all the work she did to get this together today. She's amazing.
Well, it was a team effort.
But there's more. One of the wonderful parts of this grant has been the group of people we've brought together to work with, and we have 3 wonderful quality improvement advisors. Michelle Cantor, please stand up. Jenna Pollack, she's already standing. Danny couldn't be here today, and Lisa Cacone, who was our nurse quality manager, could not be here. And then we have our extraordinaire Kelly Christensen and Meredith in the back. So the Transforming Clinical Practices Initiative was originally designed to take groups of all shapes and sizes of all geographic regions and take those groups, whether they be primary care or specialty care, and bring them up to speed in terms of value-based medicine. Under the previous administration and the Affordable Care Act, there was a tremendous amount of momentum, and our job is to keep that going forward. Much of what we have done has been to prepare groups for value-based medicine and eventually MACRA and MIPS if it gets to pediatrics. There have been so many learnings from this, and Dominique will talk about that briefly. But one of them has been our amazing partnership with all of you through our quality improvement advisors. And our team. We've gotten to know so much about all of our affiliate practices in San Diego. And there was a bonus that we didn't anticipate when we started the grant, and that was the association we developed with the FQHCs. We have a fantastic relationship with North County Health Services, Neighborhood Health Centers, and Vista Clinic. We had no idea how much we could do together, and it's in just 18 months, it's been rather remarkable. It's also been fabulous having a partnership with Children's Orange County. Dr. Sarah Marchese is medical director so she's actually one of us, but she's medical director for Children's Orange County, and we're so glad to have you down this morning. Dr. Mike Weiss, who's one of the medical directors for the project, couldn't be here today. Mike sends his best today. So I'm going to stop. I was going to stop. One more thing. What's been so rewarding to us has been learning from all of you. And this is actually our second learning collaborative. We held the first one last year in the fall, and it was very well attended and actually a very powerful evening. And we decided to keep these going, and that's what today is. But we're learning from you and learning best practices and sharing. A lot of what we've done together has changed us all. So it's an exciting day, and I thank you again for being here. Turn it over to Dominique.
Thank you, Dr. Page. Welcome, everyone, to the Southwest Pediatric Practice Transformation Network, TCPi Learning Collaborative. That's a mouthful, right? So when Chalk and Rady partnered to apply for this TCPi grant from the Centers for Medicare and Medicaid Services Innovation Center, we decided to call it Southwest Pediatric PTN, and we've really enjoyed the process over the last 18 months working together. And when we were sitting down to plan this learning collaborative in short order, we recognized that marketing for this started with not a lot of lead time, because we were so fortunate in order to bring this to you. Dr. Megan Grant Nierman has come out from Colorado. She is a national faculty member from CMS who has, in her practice in Colorado, gone on a practice transformation journey, and she's going to share her practice's experience with you today. And we're so excited to be able to do that. So we're able to form this learning collaborative quickly. And Dr. Page, Dr. Whitney Edwards, and the planning team, we were looking at it, we thought, what is helpful information that we could bring? So we wanted to look at what is the quality improvement process about? Well, it's looking at data. It's looking at things that can be addressed by the data, finding areas for improvement that can improve the efficacy of the care, improve safety, improve patient satisfaction, and improve outcomes. And then we thought, you know, that's the triple aim, right? You hear that phrase a lot. But what about returning the joy of practice? And Dr. Grant Neerman, and others who are speaking today can share with you that actually their lives are smoother now. They get to go home to their families. She's nodding affirmatively. So she will be covering that as well. So we have approximately 233 practices throughout Orange and San Diego counties participating in the Transforming Clinical Practices Initiative. That represents approximately 300 locations between Orange, Southern Riverside, and San Diego. To date, all the practices have graduated from phase 1, and we have 95% of our practices in phase 2 right now going through the phases of transformation. We've conducted needs assessment with the quality improvement advisors, we've developed performance improvement action plans, and some of our speakers today will be talking about those quality improvement plans and progress that they've made through whether they've had QI initiatives before TCPi or in support through TCPi. And then you can see all the locations here. And then what we have here as our major goals is it's not just about cost, it's about patient satisfaction, looking at what is the unnecessary utilization. So we're studying 6 areas in this project, 6 common pediatric conditions, acne, acute gastroenteritis, community-acquired pneumonia. Let's see, we have bronchiolitis, headaches, asthma, thank you. I knew there was another A, sorry. And so what we're trying to do is, what are the unnecessary visits to the ER? What are unnecessary referrals to specialists? What can be addressed in the medical home setting? And that's what we're looking at. We have specific metrics within each of those 6 pediatric conditions. And again, as I mentioned earlier, not to belabor the point, but really it's about patient and family engagement. That's something you're going to hear today. CMS is big on this acronym called PFE, Patient Family Engagement. And the concept of involving parents through family advisory councils, patient and family advisory councils, getting their input and thoughts on how to enhance your practice's experience. And seriously, believe it or not, it really is one of the most heavily weighted key success factors in practices transformation processes. And we're going to hear more about that today too. All right, we have our first speaker, Dr. Morris.
I'm in charge of pediatrics at North County Health Services, and North County Health Services is a large federally qualified health center that Dr. Page talked about. We're actually up to 294,000 patient visits with about 60,000 users that are medical and about 12,000 dental users. And we have 12 sites now, 9 of which see pediatrics. And we counted up all of our part-time, per diem, regular clinicians. We have 136 clinicians at all of those sites. So a massive amount of clinicians and trying to coordinate care with our patients. One of the things that perhaps stands out, we were previously accredited with the Joint Commission. So we received our initial Joint Commission accreditation back in 2000. We went through 3 reaccreditations. And then we got to doing some thinking about, is this the direction we want to continue to go? We learned about patient-centered medical home, and we decided to do a shift in where we were going to go. And so we decided to not renew our JCHO accreditation and went for PCMH recognition, which I think after a year of preparation, and JACO helped. So, a lot of the things that we see with the Joint Commission are similar with patient-centered medical home, but there's certainly not a complete translation between the two. So we got our initial 5 sites were recognized in December of 2012. And then we went and got 3 more sites the following year. And then we've now actually gone through 2 cycles. So in December of 2015, we were recognized for our 8 sites. And just about a year ago, we actually launched Paris, California, not Paris, France, unfortunately. Anyways, we're working on getting them recognized as well for sometime later this year. So next slide. So patient-centered medical home. What is a patient-centered medical home? So I kind of think of it, it's a team-based care model that's transforming. You're going to hear lots about transforming today. So transforming how healthcare is organized and how it's delivered. And as far as primary care with children and teens and adults, and you'll hear the catchphrase, it's designed so that that group is going to get they're going to get the care when they want it and where they want it, and probably most importantly in a manner that they can actually understand it, with the ultimate goal of increasing healthcare outcomes. So there's 5 attributes in a patient-centered medical home: comprehensive care, patient-centered, coordinated care, accessible services, and then quality and safety. And quality is bolded because I'm going to talk a lot in my talk about quality. So we'll go ahead to the next slide. Okay, this is one of those, my team with the, I have to click it like 17 times. So there's 6 standards for patient-centered medical home in 2014, their 2014 version. The first one is access, and then which then goes to team-based care. And then we click it again and we see population health management. And these things drive me nuts. Case management and support. And care coordination and care transition. And lastly, performance measurement and quality. So go to the next slide. Okay, so we're going to focus today on the 6th standard, which is performance measurement and quality improvement. And so when you go to become a patient-centered medical home, there is there's the 6 standards, and then there's lots of metrics within each of those standards. And each of them are assigned certain point levels, and they add up to 100, like we're all used to in grade school, and some are weighted more than others. So within this standard, you'll see measuring patient and family experience, measuring clinical quality performance, measuring resource use and care coordination. And again, today I'm going to talk a lot about quality, so implementing CQI, or continuous quality improvement. You'll note that's a must pass. So if you can't do that one, you're not going to get your recognition from PCMH. So it's like one of those, action potential thresholds. You got to hit that. And then you have, besides just having it, then you of course have to demonstrate that you're doing this continuously with your CQI, and then the other metrics, report performance, and using a certified EHR. Okay, so continuous quality improvement at NCHS. So we have an annual CQI campaign. And so instead of just having our quality department say, okay, here's what you're going to do, there's lots of pomp and circumstance. And we'll go into that. So with that campaign, we ask our various groups that are participating, they actually are going to have an administrative and a clinical project to work on. And then, of course, you're asking, well, how do you choose, or what projects should you be picking? So if we go to the next slide, this is where it becomes challenging. So you're in your practice and you see this big bubble. And so for those of us that are FQHCs, I see Jim smiling because he knows what this slide represents. You see, okay, you've all these integrated networks that you're asked to participate on. And in the past, FQHCs were sort of like, yeah, they're there. But now it's like, oh, no, we need you. The government's told us we need you. So you're involved in all these networks. And then you've got your HMOs who have all these HEDIS measures. They say, you know what? We want you to do good on these measures. If we do good on these measures, then we get more money from the state. Now they're actually throwing money behind these measures, and some fairly significant money. TCPi, Transforming Clinical Practices Initiative. You heard from Dominique. Meaningful use, so you're implementing your EHR. You have these measures there. UDS is from the government. For us, we have measures that we report to. Oral health, so because we have dental, we have a lot of oral health initiatives, All Heart Project. So when you take all those things together, there's 183 different measures that we're asked to report on. So you couldn't possibly take all 183 and put your time and your energy into all of them and come up and have good product from that focus. So you have to figure out what you're going to focus on. So what are your drivers? What should you be thinking about? Are you going to chase the money? Well, no margin, no mission. So that may be important for practice survivability, that you're going to have to focus on some of those that are going to bring you money. Are you doing it to satisfy the regulators? They say, hey, you need to pass this measure, or we're not going to certify you, or we're not going to make you eligible for receiving other funds. High clinical impact. So that's the part, the clinicians in us. We want to work on things that are, if we do a good job and we transform care, that it's going to really have a meaningful experience for our patients. Opportunities for collaboration. So is there opportunities to work with other clinics, other healthcare systems, in grant requirements. So sometimes we end up, and you could almost say, chasing the money with that. Sometimes we chase the money with grants, and sometimes the grants are actually, they're great, but again, the projects are part of that. And the issue there is you just can't focus on everything. You may have to report on everything, but you can't really put all your time and energy into, and you just have to figure out, and sometimes some of the measures are good for 3 or 4 different areas. You're like, you know what, this is something we want to focus on. Okay, next slide. Okay, so with CQI and NCHS, who's involved? So last year we had 11 different groups. So we asked each of the health centers, and even some of our health centers, there's multiple groups. So like our San Marcos site, there's an adult group and a pediatric group. They're on separate floors. And we get some of the groups to actually collaborate with our women's health department and behavioral health. And so anyways, we had 11 groups participating last year. You see the little PDSA, Plan, Do, Study, Act, which is, it's like the first thing you learn, and any of you that are clinicians and participating in maintenance of certification, if you didn't learn it before, you've certainly learned it now. So one of the things that we've done, that instead of it being a chore, we've ended up making a lot of pomp and circumstance as far as campaigns, and we actually give out prizes at the end. So you get the little competitive nature, the competitive juices. So obviously if you're in a small single practice, it's hard to have competition. But if you're a part of a group, a larger network, then having competition between those groups is certainly something that's in the cards. So here are our themes that we've had. So you'll see the top right there is in 2011 and 12, CQI or die. Arr. So it was sort of like a pirate, Pirates of the Caribbean theme. There's Dr. Ellis was one of our former CMOs, and Dazel's our COO. And then you have in 2013, welcome to the 2013 CQI Hunger Games. May the odds ever be in your favor, right? And then 2014 and 15, we kind of used the Academy Awards. Of course, after last week's Academy Awards, it might have been an interesting conversation piece. And then this last year, we had the Star Wars, the CQI Reawakens instead of the Force Reawakens. And then the theme is actually hotly debated. It's gotten to be so fun that everybody's trying to pry the theme out of our quality department. What's it going to be this year? Can we guess? And so it's actually going to be unveiled next month. So stay tuned. Okay, so our department, so our quality department, what are the things we're actually looking at from the groups that are participating in projects? So they're looking at activities and goals, and again with demonstrating improvement and trying to base it on prevention as well as management. They're looking at the actual projects, how complete, how comprehensive, the impact. So again, you may have a good project that may only work for your site, not the other site. So is it transferable? Is it innovative? Is it something that can be replicated elsewhere? The presentation format and BGR is building great relationships. I'll go into that a little bit more. And just your ability to collaborate even with some of the other groups in doing the projects. So you'll actually see, as far as presentation format later on, you'll see a nice little presentation that my group did last year. Data and tracking demonstrations. So again, you can put on a big project, but you have to be able to actually show what you're doing and demonstrate that you've made some progress. And sometimes the projects are great and they're unable to demonstrate improvement, but you can see that if you keep doing the PDSAs involved, that there's actually great potential. And then there's a CQI tool and team participation. They're really looking at broad participation within the group, so it's not just the clinician and the site manager. Okay, so you'll notice that on the agenda it talked about ABCs of patient-centered medical homes and quality, and I kind of changed the title after they put out the agenda, and so I added engaging staff. So, and we spent a lot of work on that, and I know you'll probably hear a little bit about that from some of our other presenters, but I thought that was really important because you can't just decide one day, oh, we need to do CQI and let's just start it, and without having some background on engaging staff. So some of the things that North County Health Services has done that's really greatly helped us. So I mentioned the BGR campaign, and what that is around 2008, when the Affordable Care Act was starting to come into fruition, we began to realize that if we don't improve as a whole, not just from our site, but as an organization, when patients really have choices, so as opposed to you have to go to an FQHC versus you get to go wherever you want, including in the private sector, that if we didn't transform ourselves, that we're going to lose market share. So that was sort of the driver, but it's become now integrated into our culture. And so we have, I think, 8 different measures, and everybody participates in BGR, to the point that, if a doctor's not nice, the staff will call him out. You're not being very BGR. And so we kind of all hold each other in check. And then care and care repair. So care stands for connect, appreciate, respond, empower. So this comes from the Institute for Healthcare Communication, and this is something that we've also implemented at NCHS. And so everybody participates, whether you're the janitor, whether you're an MA, a manager, the clinicians, everybody has to go. And so everybody's been through care and care repair, and then as we hire people, we put them through the trainings as well, sort of a train the trainer program. We have an annual all-staff meeting, which is coming up. So one meeting where everybody is invited to. Not everybody's able to come, but somebody's got to man the fort while we're gone. But we pretty much, for one afternoon, close down all of our clinics. We also do a clinician-specific retreat that we do every year. So see a couple of our old clinicians here and a couple of our current ones, and they've all remember what we used to do in that. And really the idea is to align goals and align ourselves, and what do we want to do. Quarterly department meetings, so all of our departments. So a lot of times, okay, what are we going to do about bronchiolitis or asthma that we heard with TCPi? Well, some of it is aligning ourselves. So we have quarterly meetings, and for us, we had to take the algorithms and tweak them because we couldn't just accept somebody else's algorithms. So we took them and we tweaked them so that they work for us. Got it. Provider balanced scorecards. So transparency. Transparency is huge. If you want to get anywhere as far as improving quality, you have to be transparent. So we have a scorecard, and I'll show you a picture of that in a second. We use 5 pillars: quality, finance, growth, staff, and service. These were concepts I borrowed from Dr. Stephen Beeson, who used to work for Sharp Healthcare. He wrote a book called Engaging Physicians, Manual to Physician Partnership. There's a lot of books that I want to read that I never get to. I've read his and strongly recommend it if you're wanting to engage physicians. We used a lot of his concepts and have adapted them. And then one of the messages that he had in there was, coming up with a code of conduct for patients and staff. So we actually took a year, and you can't, and I have a sample of it too, you can't just adopt somebody else's code of conduct. So you have to come up with your own. But we took a year and developed those codes of conduct. And so there's one for our code of conduct to patients. It's actually up in the exam room. It's signed by the clinician and both MAs. Like in there, it's like, we'll be respectful of your time, and we'll communicate our plan and whatnot. And then there's one for the MAs that's up in their lounge room. So, it's right there front and center, so you can't run away from it. And then the message on that was, if you're trying to engage staff, you don't just turn on a switch one day and say, okay, let's engage our staff. There's a lot of things that you have to do over time. So this is our balanced scorecard. So you can see there's the quality metrics. It's about 50% of the actual scorecard. And this is 3 years ago. It's blinded, but it's mine. So if you want to take notes, I felt okay with sharing my own scorecard. So we currently have 10 measures in quality, and again, I've made the point you can't focus on too many measures, otherwise the clinicians are not going to pay attention to any of it. So we have 2 EHR measures. We have 4 currently, kind of like meaningful use organizational measures. One of them is risk stratification, which is really important for population health. And then there's 4 HEDIS-like quality measures that are on there. So a total of 10 currently. You'll also see growth, and growth is, I think, on here, and it's one question. It's how likely, if you're interviewing patients, how likely are you to recommend this clinician to one of your friends or family member? Our patient SAT has 4 questions that are specific only to the clinicians, and it's easier to read it up here. So basically, one of the really big ones is how well did the clinician explain your treatment to you? And did they have an idea what was about your health history? So one of the things we see that when we went from paper to EHR is real easy to pick up a paper chart, look at it, know what was going on. Now you have to kind of train yourself to actually go in the EHR, look at the last note or previous notes before you go racing into the room. So you had to do a little bit of change from that standpoint. We have productivity in there as well, which is worth 20%. And the last one is service. A service is a survey that twice a year is sent out from to our line staff regarding providers. So there's 7 questions in there. Does your provider treat you well? Do they show up on time or let you know if they're going to be late? And that alone probably has changed culture with the way providers interact with their staff. Okay. And then the codes of conduct, just again, I mentioned them. There's one, our commitment to our patients and our commitment to our staff. And this is what we came up with after many iterations over the course of a year. Okay, so engaging team members. So we were talking about engagement. Why is that important? So you need to be able to move QI from this, we have to do QI again this year, So you want to move it from that dynamic to we want to, and when do we get to start on the next project, and again, what's the theme going to be? And it's really important. You want to involve the entire full care care spectrum, so that part of the team. So the front desk, the back office, the providers, the managers, the records, whoever might be involved in that healthcare delivery. It's really important to have regular meetings, so you can't just say, here's what we're going to do, and then, okay, how do we do at the end of the whole session? So we have regular meetings. In the beginning, we meet more frequently when we're doing our projects, and once we get going and there's less stuff to figure out, we'll meet a little bit less frequently. And then you'll see huddles. So we do huddles as far as the meetings, we do huddles as far as the patient care delivery, as far as satisfying the endeavors. And I think some of you may have seen my video, the huddle video, the one where my pant leg was up a little bit. Hopefully that didn't distract you. Thank you to Dr. Schultz for pointing that out. But in huddles, I made a lot of important points in those videos, and I just summarized some of them here. So you get to do proactive planning, basically making your life easier. So if you're seeing patients and you've pre-identified labs and newborn notes and guidelines, so you'll see we're like, what's that headache algorithm again? Oh, we have a patient coming in for chronic headache, so let's make sure that algorithm's right in front of you so that you have to trip over it to not use it, as I referred to. The whole bi-directional communication. Instead of me telling my team, here's what you need to do today, I hear from them telling me what I need to do today just as much, sometimes more. So I like to call it curveballs. So everybody has curveballs in their schedules, trouble with the curve. And sometimes it's the difficult parent, sometimes it's the complicated patient, but ones that if you don't prepare for it, one patient can just, the rest of your day is behind. So you guys all know what I'm talking about. And then basically the huddle really empowers and brings up the level of responsibility for the entire team. So again, it's not just about taking vitals and putting patients in the room. The staff are really engaging with you. And so my staff it's gotten to the point now because of the relationship I've built, they're like, oh, we want to talk to you before you go in this room. Here's what we found out. It says they're here for this, but this is why we think they're really here today. Thank you. That was really helpful. It just saved me 10 minutes, and so I get a lot of that now, which I'm really happy about. So I'll go to the next slide, which is actually going to play a 2-minute snip from the actual huddle. So my team has prepared a nice list for me. I have a list with all of our patients for this afternoon. I'm on a 4-hour stint. So guys, let's go ahead and go through our list of patients for the afternoon. So starting at 2 o'clock, it looks like we have a newborn visit, Jack, who was born at Tri-City Medical Center. So I want to make sure, have we gotten our newborn notes yet?
Yes, they're on imaging.
Okay, great. So I'll go ahead and I'll print those out so that I have those. Our next appointment at 2:15 is Ronald. It's going to be a 14-year-old physical. As you know, we need to do a PHQ-9 depression screen. So let's make sure we have that in the chart.
Okay. And also a reminder that patient has fasting abs pending, so just a reminder to the parents when they show up. Please. Okay. Thank you.
Oh, that's great if you guys would do that, but sometimes I forget to remind the parents.
Okay.
All right, 2:30, Teresa, a 16-year-old with follow-up headaches. So that's, I think, one of the ones that we're working on that algorithm through the Rady's project.
I have it here. I'll make sure it makes it to our patient.
Oh, in the jacket. Okay,
in the
great.
jacket.
That's a good trigger for me. So when I'm in there going over treatment options, I remember medication doses and what's next. Thank you. Okay, our 2:45 is Jackson, 9-month-old physical. And I think that one is going to be part of our CQI project, our continuous quality improvement for doing the fluoride varnish.
Yeah, I could do that, and I could also do the reading outreach also.
Okay, so you're going to give them a reach out and reading book, and then you'll be able to actually put on the varnish?
Yes.
Okay, great.
All right. And if you guys need anything, let me know, please.
Okay.
Thank you. So what you saw actually in that video, I talked about, a couple of quality things we were working on. We were doing a CQI project with dental. They also held me to task, with depression screening, which was another one of our projects. And so the team is actually helping me, not only with patient care, but even with some of our quality projects. So I wanted to go over a sample project we did at NCHS this last year at our San Marcos site. And so those of you probably recognize Edward Munch's The Scream. So that's why sometimes I think about like when my depression patients come. So our team had medical assistants, panel coordinators, clinicians, our clinic manager. We had a couple of patient liaisons and a behaviorist that was actually all part of our CQI team. Before we started, we completed the PDSA, so the Plan, Do, Study, Act. I'm not going to read all the stuff that's on the slide here, but this took place over about 6 months this past year. So a few slides that are integrated into the next video that I'll show you. So YouTube can PHQ, that was our title of our project. So the aim, so 2 things we wanted to work on was improve our clinical depression screening, and that was going to happen at all visits, so not just at physicals. So whether it was acute care, well child, or sports physicals. And then we're fortunate as an FQHC, we actually have behavioral health specialists that work with us, and so we were trying to improve our ability to do warm handoffs for those patients that had positive screens. Okay, so intervention. So some of the things that we did. So our panel coordinator identified anybody based on the age or who had not already had a screen previously within the last year. They got together with our huddle and says, okay, this one needs a PHQ-2 or a PHQ-9. She gave the screening forms to the MA, so those were going to end up in the chart jacket. And then the pod gave the forms. And then basically, if somebody had a positive screen, they put a blue sticky right in the middle of our computer screen. So I basically, again, would have had to physically move the form, because if you are familiar with the HEDIS measure, it's not just enough to screen the patients. If they have positive screens, you have to actually come up with an action plan. So that's where we're getting stuck with, okay, we have to come up with an action plan, and we would just ignore the actual score sometimes. Provider, after not ignoring the sticky note, put their interventions. We engaged with a liaison to help us with the behaviorists. Hopefully, if they weren't busy, we'd get them in that day, and if not, we got them an appointment. And then our panel coordinator held us to task. So the next day, they said, okay, you had 3 that were due for a screen, you succeeded on 2, get better. And so my panel coordinator stays on me like all the time, and the rest of our team. And then we had weekly updates. So one of the things that we saw during the project is some of the data wasn't matching what we thought we were doing. And so here was our data. So we had 2 providers here. So one went from 30 to 47% over the course of the project, one from 28 to 35%. And one of the things, like I mentioned, was our report. The way our report was designed, it was only capturing if you satisfied the measure. So if somebody else satisfied the measure, which is still good, because the patient's getting taken care of, it wasn't giving you credit for that. So that's why the scores are lower on here and should have been higher. But that's part of doing a project, and sometimes you identify flaws in the project or the data reporting or whatnot. So because of the flaw, we didn't meet our UDS goals, but that's okay. All right, so making the case, and this was part of our presentation, so 50% of teens with depression are often missed unless you have an integrated formal screening. And why is it important? Well, it's a treatable condition. We had resources internally, so to not utilize them just sort of like would have been a failure on our part. And really, we didn't spend any more money. We just changed the flow in what we were doing. And just doing some little tweaks, we basically enhanced what our panel coordinators were doing, and we were able to achieve goals without adding any more money costs. We're on track. Okay, so having fun with CQI. So again, changing this from this is a a chore to we want to participate. So this is one of the 11 projects that was done. I was actually part of it, and I wrote the screenplay one day. I wasn't paying attention at our clinician retreat, or at least for a few minutes. And then my daughter, I said, here's what we want to do. And my daughter, oh yeah, I can do that. I can film it, I can edit it. She's 10. It's like, wow, you're really learning a lot at Digital Gym. This is great. You know, of course, when it came time to the editing part, well, I don't know how to do that. So it's like my wife and I crash course on iMovie on the, on our Mac, but we managed to get it together. So it's not like perfect, but it's fun. So I'm going to go ahead and play this.
Han has left me. I feel so down. I could just jump off a Death Star.
Obi-Wan, how can we help Leia?
Luke, use the force of a PHQ screening tool.
Great idea, Obi-Wan. Hello, Princess. I would like to try and help.
I'm not sure anyone can help me.
I would like for you to complete this questionnaire. That perhaps the right answers can point us in the right direction.
Luke.
R2, how do we help others like Leia? Thanks, R2. Leia, have you completed your questionnaire?
Yes, Luke, I have.
We didn't know when you first showed up at this battle station, but it appears that you have clinical signs of depression.
Who would have thought it?
We would like to offer you a visit with one of our integrated behavioral health specialists today who can talk to you about your depression.
Wow, is that really an option? I'm beginning to feel the force strong within me.
It sure is at Ain't CHS. Take that, depression.
That was having fun with CQI, and that was part of our presentation after the whole project. And so, and again, everybody felt part of the team. So anyways, that was my first attempt at best original screenplays or adapted screenplay, however you look at that. Okay, so last slide. So summary and lessons learned. So patient-centered medical home recognition. So I think a lot of places will get their PCMH, their level 3, and they'll say, okay, we're level 3, and I'll submit that that's just the beginning. So it's one thing to be recognized, and then you have to actually do the work, and the patients really need to get the benefit out of the fact that you're recognized. Picking a few measures, again, you saw how many measures that we have to report on, so my advice is do great work on a few measures and started trying to do average work on all of the measures. Culture change, it's going to take time, and it has to really permeate all levels of the organization, from those that are cleaning the clinics to those that are running the clinics and anywhere in between. Engaged staff is going to translate to engaged patients. And ultimately, if you engage your staff, they're going to want to participate in doing CQI. It'll be part of the fabric. And then team huddles, so opportunities for optimizing patient care and really empowering staff to bring them up the level of their participation up. And you saw that we were able to actually integrate quality and what we're trying to do with our quality efforts as part of those huddles. And then the last thing that I didn't talk about, so if you do have patient-centered medical home and you're board certified, you have to do your 40 or 60 units every 5 years of quality projects. So you get, just by doing a CQI project as part of PCMH, you get 40 units of MOC credit. So you have to do a little submission. So I got my 40 units for my work with the Star Wars videos with dental and PHQ. And that is it. Thank you.
So thanks again for having us here in California. It's really fun to leave Colorado and come to see palm trees. Very exciting for me. So as I said before, my name is Megan Grant-Neerman, a family practitioner in Salida, which is rural community in the heart of the Rockies, and it's kind of south central Colorado. I'm really humbled to be here amongst so many hardworking physicians and just kind of share my experience in practice transformation. A trusted friend and mentor of mine told me that pediatricians are really nice, and also that pediatricians are amongst the most radical forward thinking of all the physicians, and so I trust that I'm in really good company today. I've been a TCPi national faculty for about a year, and then I've been practicing in family medicine in Salida for about 5 years in private practice. Our little clinic, we provide full spectrum care, so everything from delivering babies, doing C-sections. We see all ages in the clinic. See all of our patients also in the hospital or in the intensive care unit, and then help be with them through end of life as well. So it's a true cradle to grave kind of experience, which I love. This picture is one of my favorites right now in my early part of my career. These are 4 generations, and I take care of all of them. So little baby Ellie is in her first year of life, and great grandma Jane is, I think, just turned 93. So it's really an honor what we get to do to take care of 4 generations of a family. It's awesome. Is anybody here from a rural community? Most of you are here like San Diego, right? So not small. But how many people here are in smaller practices, like less than 10 docs or less than 5? So a few in more small clinics and practices. So my office at First Street Family Health, so we're a private practice. There's 4 docs and 2 mid-levels. We have about 22 staff now. And as you said earlier, our community is about 5,000 people, but we're pretty rural in the mountains. So we take in patients I have some patients that drive up to 2 hours away to come in to see us. So our clinic alone impanels we're almost up to 8,200 now patients, 23% of which are children. I think in 2016, we saw 1,176 well-child checks, total pediatric visits, about a little over 1,200. So it's about 21% of our patient appointments in 2016. 4 years ago, my senior partner, Mary, who's not in that picture, had the foresight to enroll our practice in the Comprehensive Primary Care Initiative. So that was a 4-year experimental practice transformation pilot project that CMS did, during which time, so that was 2012 through 16. And during that time, our practice had to sort out ways to transform our way of providing care, which is a lot of what you guys are doing now. We kind of had to forge our own path and create our own ways of doing things, and there were definitely a lot of lessons and bumps and bruises and that kind of thing. But 2 of our major cornerstones that helped us succeed would be team-based care and patient-family engagement. So with that in place, those 2 things in place, we were a little more able to absorb a lot of those other elements of that practice transformation circle that we started out with this morning. Once CPCI was done, we applied for a CPC Plus program, which is one of the advanced alternative payment models through CMS, and we were accepted to track 2. So we just started that. So we have 4 more years under that, which is kind of it's not the same, but very much mirrors some of the TCPi things that you guys are doing. So my point here is that when we started our transformation, Mary, our senior partner, was gung-ho and excited about all of this, and the rest of us are like, oh gosh, really, we have too much work to do. We don't really want to take on more meetings and more milestones and metrics. Really, why are you dragging us through this? After all, she was going to retire in a year, so she was going to ride off into the sunset and leave all this stuff for us. So we're a little hesitant, but now, after only 3 years, probably even after 2 years, there's not a single person in our office who would ever think about going back to the way we did things before. And so I think that says a lot, and we were very thankful to Mary for getting us kind of launched off onto the right foot. on a personal note, when I was in residency training, our residency program was trying to become a PCMH, and I was that person in the back rolling my eyes. I hated all those words, data, PCMH, quality improvement. I didn't even want to think about that. I wanted to be a doctor, and that's it. But the fact that in 4 years from residency to now, that I'm even doing TCPi national faculty, that I'm standing here, I think is evident to the fact that I really believe in the power of what it does for practices, for financial viability of practices and clinics, and I'm also really passionate about its importance for small clinics, rural clinics, because I think rural practices and small practices truly are such an important backbone to our healthcare in our country. And sometimes we feel a little left behind with these massive organizations and Kaiser Permanente, and little practices kind of feel left behind from that. But I really am passionate that small practices and rural practices are an important backbone. So it's important to help that part be able to do this transformation too. And so anyway, goals for today. My first goal was to just be real and honest with all of you about this transformation journey. All of us providers in primary care work hard every single day to provide care, really good care, to as many patients as humanly possible that you could squeeze into a day, all while drowning in the paperwork, data collections, EMR challenges, meetings, administrative burdens, all of that. We all know. Some of us wake up in the morning and say, who the heck signed me up for this? I just wanted to be a doctor, and now we're doing all this transformation, and it's just truly, some of these TLAs that we're drowning in, the 3-letter acronyms, are completely overwhelming. But my hope is that maybe today we just kind of step back from all those TLAs and metrics, milestones, data, all those words we've heard enough of, and just think about some tangible ideas for a small practice that could maybe just a few little nuggets that you can take to actually use in the next day's efforts of transformation. And then again, to provide a little bit of hope for small practices or rural practices, to know that it's doable also in that setting, and it's totally worth it, worth the time. So for our practice, the cornerstone of transformation was, as I said, team-based care and PFE, or patient-family engagement. Without these two things, we would be unable to accomplish anything else in this transformation journey. Team-based care has allowed for our practice improved capacity and access, which I think are different things, improved clinical quality, performance, provider and staff satisfaction, provider efficiency, patient satisfaction, et cetera. Our patient-family engagement, the way that we do it is pretty strong with PFAC, but there are a lot of different ways to do patient-family engagement within the milestones of TCPi, so we'll think about that too. Does anybody here already have kind of some form of team-based care in their clinic? A little bit? I see some nodding. So for those of you who maybe don't have that quite in place, you've got good best practices kind of amongst you in the group to learn from and to share. So just a thought, my father, who practiced medicine for 30 years, that's him, a long time ago, that was in an era of medicine where you didn't really need much of a team approach to accomplish what you needed, right? A lot of us might have been to a doctor during that time. One doc, one medical assistant, 40 patients a day, in and out, piece of cake. Billing was simply a $15 office call, cash at time of service, walk away. The electronic medical record, yeah, right. The medical record, like a little index card with 2 lines. And I still have some of my dad's old medical record index cards from his patients. And so that is such a different world from what we do now, which is like a 6-page typed document for every sore throat, right? Does that make sense? But that's what we're doing. So it's different now that all the things that we have to do, that we kind of talked about in that last presentation, that can't all be done by one MA, and it can't all just funnel down to the provider. The MA can't just room, take vitals, and walk away, and then all those other things we talked about just kind of funnel onto the practitioner, and it's not possible really in today's world. So in order to provide timely access to care, coordinated population health, consistent screenings and interventions, we have to redefine this team concept. It's time for providers to learn to share the control and the responsibility of the patient care to trusted care team members and create space to allow everybody to work at the top of their license. When we accomplish this, we reclaim the time when the physician ends the day and goes home happy and in time for dinner, most of the time. So for our office, recognizing the need to improve this efficiency and provider sanity is what drove us to do a team-based care model. So when I joined out of residency, our clinic was just one doc, one MA. Our MAs bickered amongst each other. Each MA was kind of protectively entrenched in this idea of protecting their own doc. And so we were four little silos working independent. So coming in new to this, I thought, oh, I'm not going to make it here if we don't do something different. So I knew we had to kind of create something a little more efficient. So I proposed a team-based care model, which would mean hiring quite a few more medical assistants, or at least a couple more. And of course, I was met with a lot of skepticism and doubt, but I'm stubborn and bossy, so I persisted and hounded all my physician partners, probably 2 years, I think it felt like, with different ideology and like trying to convince them with every passionate voice I could of why we needed to do this. But they had some really important concerns, and some of them you might have also. So first question was, where will we find these people, these additional MAs, right? We are in a tiny community. In this rural community, it's not like there's 3 community colleges and a trade school where they're just putting out MAs. So the supply is limited there. We live in a sort of a touristy retirement community, so a lot of the residents in Salida are uninterested in leaving retirement to come work for us. And then additionally, because we're in a Colorado mountain town, the elevation is high, the cost of living is high, and since legalization of marijuana, half the workforce is high. So we find it kind of hard to find people to hire. But and some of our other challenges would be like our physical space. Where physically do you put that many more people to do their job? When our building was built, of course, it was built for these 4 silos, and so just the logistics of physical space had to be rethought. We had to get some creativity and to figure out how to foster those team conversations. Of course, who's going to do all the work of coordinating this transition, training, all that sort of thing, and who's going to work on culture change? That's, as you guys have all experienced, that's probably of all these things one of the hardest. Who's going to convince our staff that we need to change what we're doing? Staff and physicians both. So these are all really important points. But my biggest hurdle, as you imagine, as my partner, Dr. Berkeley, would say, what about the money? So, fine, we had to tackle that first before we could tackle those other problems. So what we basically needed to do, what I needed to do to convince my partners that we should hire a bunch of more MAs was to calculate a return on investment. And I'm not, a financially minded person, so anybody here who is, please forgive the simplicity of what we did, but just tried to create a simple return on investment idea. So very rudimentary, but simply, what does it cost for an MA for a year? The salary and training and benefits and that sort of thing. And then we just looked at our lowest payer for our most common code, which would be a Medicaid 99213. So how many Medicaid 99213s do we have to see to pay for an MA? How many Medicare annual wellnesses do we have to see to pay for one MA? And just create a few different numbers to show them it doesn't take that many more appointments to pay for an MA for a year, and then create kind of a flow model. It says, okay, here's how we can change our flow to squeeze in 2 more patients here, a nurse visit here, and become more efficient, increase our access so that it basically pays for itself by freeing up physician time to see more patients and get done earlier. So. It takes a little time to realize the return on investment. I think at 9 months in, my partner's hair was starting on fire, like, oh my gosh, look at the numbers are upside down, we're losing all this money. 9 months. But by 15 months, we were already starting to see a return on our investment just from the increased volume we were able to see in our practice without staying open more hours later in the day, working through lunch. So it didn't take that long to start to see that return for our practice, which was pretty cool. So once we gave them our workforce, or gave them our meaningful return on investment pitch, we could return to those other topics. So like regarding staff. So again, we couldn't just go out to the community college and pick up 10 new MAs from down the street. So we had a couple front desk staff that wanted to train and learn to become an MA. So we kind of learned from within, trained them from within. We stumbled across a gal in our community who was traveling 2 hours away to a junior college to become an MA. So we jumped on that and made ourselves a training site for her, and then hired her. And we're trying to do that with a second medical assistant. So those are few and far between opportunities in our community, but we were able to capitalize on that. And then incidentally, when we take people from our front desk in our little town, we have to backfill the front desk. So then we go steal people from Walmart, because if you work at Walmart, you have thick skin and you can handle the front desk. So that's kind of how we backfilled that, but it's actually been really great. As far as culture change, that's always a work in progress. You guys are all part of the growing pains of culture change now, and we always will be, I think. So as I mentioned before, when we started, I think we had 5 MAs and then 3 or 4 admin staff. And some of these women were very committed to doing things the way that they've always been done. Some of these gals have worked there for 15, 18 years. So when you're trying to do culture change in your office, you might find that there's some people who are really excited to embrace change, and then there are people who are resistant at every turn. Sometimes you're tempted to just cut bait, get rid of these anchors so that you can move forward in your transformation process. And certainly there may be times when this is necessary, but we found in our practice that these particularly resistant troublemakers or naysayers, as they might have seemed, have actually been probably some of our most valuable tools in transformation. Because they are the devoted guardians to the history and the tradition of your practice. They have a really important balance that's necessary to kind of, create a balanced perspective, because we get really excited and we're launching off with our Star Wars theme and transformation and changing, and the people back here kind of hold in the reins and say, okay, see what you're doing here, but let's think about the unintended consequences to our culture and our patients that maybe when we're so excited about change, we forget. So they actually, I can think of a couple of them that gave us headaches a lot at the beginning that are our most valuable team members now, because they really needed to see the proof in the pudding. But once they saw that, and then they bought in as our trusted guardians of tradition, the momentum, you can't stop it now. So that's really fun. And then from the medical assistant's perspective in clinical task, there's a huge culture shift. And I think you talked about it a little bit earlier, that it's a big change from going to, I just do what the doctor tells me to do, to these are my patients, it's my job to prepare for the day, and I'll tell the doc what he needs to do. And that's a really awesome shift, I think. Sometimes it's a lot to handle, but for the most part, it's really great. This kind of empowerment for the MAs takes adjusting to, and they're sometimes resistant and afraid of the new responsibility. But once they get a hold of it, it's very empowering, and they're really empowered to help one another intrinsically as opposed to bicker with one another. And physicians need to make a serious culture change too, for some of us, like being able to make a transition from being the only person who's in charge of things to letting go of some of that control and empower those team members and to trust them. So there's a culture shift on all levels there that's kind of hard, but we all kind of learn together and get there when we support each other. So it takes somebody to champion that. So it was me and my RN care coordinator, Danielle, and it took a lot of work and a lot of time because we were kind of winging it on our own at the beginning. But we worked together to lay groundwork, create buy-in, put out the fires that arose amongst the staff. Also soothing some of the growing pains when people would get frustrated. We went to a couple of IHI conferences. If anybody's never been to Institute for Healthcare Improvement conferences, they're really awesome. And we learned a lot from there. These two websites, the Robert Wood Johnson Foundation has a Team Leap site. I don't know, kind of got tons of resources to transition to team-based care in that. And then the AMA Steps Forward module has a lot of really useful, tangible tools for implementing the transition. And so if anybody has a lot of free time, you can get lost in these websites, but they're really great, a lot of good resources. And we did try to spend some time observing best practices, which some of you will be able to do because there's a few of you who already are doing a little bit of team-based care. So you can observe best practices right here. In my office, when we're trying to lay the groundwork, I took my medical assistant, Brenda, out of the office on a Friday, and we drove 3 hours to Denver, and we followed around a clinician who is team-based care genius, in my opinion. He has 4 MAs and sees, I swear, 40 patients a day, but they were a machine. They were amazing to watch and learn from. So we just went and followed him around and took notes. And so there's a lot of groundwork that comes into creating readiness and learning from best practices, but there's a lot of opportunities to do that online or in person or right here in this room. So structure and function. So our structure of our team-based care, is what we've designed, but team-based care, of course, is not just one thing. There are as many practices are represented here in this room. That's how many iterations of team-based care you could come up with. So there's not just one way to do it, but generally speaking, just creating the model, going away from 1 MA rooms, the patient takes the vitals, and then everything else is done by the doc, to a team approach where there are many team members working in a coordinated way at the top of their license, for efficiency for patients. Our clinic currently has a capacity, for the most part, 1 provider to 2 medical assistants, and half the time we're 2 providers sharing 3. So we have our own and then a float. So we're kind of always evolving and massaging it, given what we have at that time. Our goal for our team-based care in our clinic, which was our original goal, but it's taken us 4 years to get to this point, is to have half of our practice impaneled to one team or the other, with one team being 2 physicians, 1 mid-level, 1 RN care coordinator, and 5 MAs for that impaneled team. So that's the next step of our goal, so that patients can identify with their care team, for example. But we have a lot of our MAs that are cross-trained to the front desk, either came from the front desk or cross-training, so that our team-based care extends through those barriers too. I don't know if any of you in your office have this wall of, well, we're the front desk, well, we're the MAs, and we bicker at one another, and it's this cultural chasm, I don't know. So having that cross-trained event has helped kind of break down that barrier so that the team includes front desk, MAs, providers. And so that's been a process too, but it's really starting to work well. So in terms of our function, the previous presentation had some really awesome examples of functions of team-based care, and a lot of what we saw there is something that we try to do in our office as well. So any of you who have ever played on a team sport, you have to huddle in the locker room to prepare for the opponent you're about to face that day, right? So it's the same deal in the office, of course. So what we do is we get together in the morning to review the day. Our MAs, usually the night before, morning of, have looked ahead to the schedule, and they come to the desk and show me, here's what you need to do today. They've already figured out which children need shots, what shots they need. They've already been drawn up. Figure out which of our annual wellness physicals we need a pap smear, who needs pro time, who needs an A1C. We might review together and point out, here's a couple of our VIPs or our high-risk patients, or somebody who maybe have called the online doc call that night before, so we can kind of anticipate any special needs there might be for that day. The nurses can see who's due for the cavity-free at 3 or the dental fluoride treatment program, and then they can just do that before I even get into the room. Sometimes we'll try to find inefficiencies in the actual scheduling. So like we look down and say, oh good, big brother has a well child check at 9, little sister has a well child check at 1. That doesn't make sense. So they'll figure out, let's move these around so mom can come in once and not have to come back twice, make it more efficient. We figure out places in the schedule where double books and same day appointments will fit, or where they shouldn't fit given what we know about the patients on that schedule. But what's exciting is that it's owned by the MAs. And what's also nice, in our small community, like our MAs know our patients clinically, socially, personally. They're probably cousins. Kind of all the nuances that come into this, and so they're able to know some of those unique needs that I'm not going to be able to pick out from the chart and help anticipate that as well. A good example, my medical assistant, Brenda, she'll look ahead and say, looks like it's snowing. We've got Louis fish coming in at 7 for our evening clinic. It's going to be dark and cold and windy. Louis does not need to be out in the cold. I called him, he's coming in at lunch. You need to see him at lunch. Yes, ma'am, whatever you say. So she just does that, and it's really great. It really takes a lot of burden, and it's so good for our patients, and they appreciate it. So on the days that I have 2 of our medical assistants, I mean, they can take time to do, they do depression screening like you guys were talking about earlier, fill out preschool forms, print off the shots for the shot record for the parents, all these time-consuming tasks that are incredibly important, but don't really take a physician to do. So before we had team-based care, I was doing all of these things in addition to the providing medical care part. But now when I come in the room, I just do the doctor thing. I play with the kid, develop a relationship with the family, and move on. So our MAs are taking a lot of ownership of that workflow. And this is another awesome example that happened, I think, 2 days before we left to come here, of just our team-based care culture now, and the nurses and what they are excited to do. So we have our evening clinics, and we had 1 physician assistant and my partner, Dr. Berkeley, doing evening clinics. So 3 MAs and 2 providers in the building in the evening. And Dr. Berkeley gets a call from across the street. Your laboring patient's precipitously gone to complete, heart tones are in the 60s. Literally, drops the computer, sprints out the door, Jamie, see my patients, and blazes out the door. And the PA's like, what just happened? The MAs, before anybody knew what happened, the 3 MAs got together, grabbed it, looked at the schedule, said, you room this one, you room this one, I'll do this, I've got shots. Jamie saw her patients and his, they were out the door on time, nothing happened. Like, it was seamless. So it was really awesome, because 5 years ago, that definitely would not have happened. And so in that moment, the MAs took charge of the situation, coordinated the care for those patients, got everybody what they needed, and saved the day. So it was really a fun example right before I got on a plane to come here to hear about. So provider satisfaction and efficiency, which is the joy in the workplace thing. This is where all the rubber meets the road, I think. We can't afford to lose any more physicians to burnout, and I think we all have friends that have left the field because of burnout. So workforce retention is critical to the delivery of health care in our country. So team-based care in our office has, in less than a year, it drastically improved our efficiency and joy for our providers, as you can see by some of the comments from the providers in our office. This is my nurse, or my medical assistant, Brenda. Our staff satisfaction and empowerment has been pretty surprising and fun to watch as well. So with all the culture change with CPCI, there's a lot of change fatigue. So when we started to then add on this concept of team-based care, I really thought Brenda was going to quit. Her hair was sticking up. She was so angry. But it didn't take long for our staff to become very reliant on each other as team members, and to feel empowered to work at the top of their license. They're not bickering as much. They're cooperating a lot more with each other. Started out being hesitant with all these new things you're asking me to do, but really the moment they felt that pride in their personal growth and professional growth and growth as an office, it's a really palpable thing, and it's fun to watch them just grow in that confidence. So patients have been satisfied with changes from our team-based care. Primarily, they're happy because they get what they want when they want it faster. We're all instant gratification people, so it's the same thing in healthcare. We're seeing more people in the same amount of time. People aren't waiting as long in the lobby to have their needs met. This picture here is kind of an exception, though. We had this little cutie was waiting for her well child check, and then I had a patient walk in from the orthopedist's office with a new diagnosis of a DVT, and they said, go to your primary care physician and figure it out. So they walked in the front desk, said, I have a DVT. So of course, you gotta squeeze that in and educate and Coumadin and Lovenox, all the stuff you have to do, which takes about 45 minutes at least. So this little girl just happily, pleasantly waited. So she actually did have to wait a long time for her appointment. Waited so long that she actually lost a tooth in my office. And so when I came in, she was so excited to show me her tooth in the urine cup that she lost while she was waiting, and had time to draw 3 pictures of herself without a tooth to show me as well. So we didn't really improve efficiency for her on that day, but overall she was still pretty happy. So patient satisfaction. Sometimes we make changes in our workflow and our business, and we think that patients are going to be satisfied with what we decided should make them happy. And sometimes we're right on target. Increased access, yeah, we're right on target with that. But sometimes we're not on target at all with what we think should make them happy. And so it's clear that we need to engage them in a more meaningful way. So we did this in our office, ultimately with our PFAC. Words that I would use to describe PFAC would be inexpensive, effective, and enlightening, very enlightening. We didn't start with PFAC in our office. We started with written surveys to get patient feedback, so we had to do that as part of CPCI. If anybody in this room likes filling out surveys, stand up. That's right, because if you stood up, we'd kick you out. Nobody likes to fill out surveys, not even the ones you're gonna have to fill out at the end of this day. But I don't think any of us really, many people don't take them seriously, neither do patients. Just circle satisfactory and turn it in. So we did surveys for about a year and realized this is entirely useless. So we decided to try this PFAC concept. We were all skeptical about this as well because we already knew how to provide medical care. We didn't need them to tell us what we needed to do differently. We figured we already know what they're going to say. They're just going to use this as a place to vent or complain about things that are out of our control to fix. After all, they should just be thankful for what we're offering them. Like, we don't need their opinion. So those were some of the feelings that we were having as we were trying to sort out a PFAC. But it was soon evident that it wasn't just another burden or barrier to prevent us from getting back to the real work of providing patient care and being doctors. That we were wrong on that point. It is actually really fun and enlightening to do. Our PFAC has helped us improve a lot of things about our daily operations and communications mostly. A lot of our work so far has been within communicating good information to our patients, but figuring out best ways to meet patients in ways that are meaningful to them and to us. I think it's been rewarding for providers and patients to break down some of those barriers and become really transparent to one another and recognize that the practice and the patients have mutual goals and they humbly want to work on them together for the betterment of the community. So when we started with a lot of guidance from the National Partnership for Women and Families, and they walked us through the process of developing our council. It's now been about 2.5 years. So if anybody's in the process of getting started there, the National Partnership for Women and Families is a great resource. And I think now the AMA Team Steps modules have some PFAC resources there that you can use also. So we started with a good template for patient family advisory councils, but it just really evolves and takes on a life of its own pretty quickly. We recruited from our clinic members from our various departments. So we had one physician, this guy, a physician assistant, some medical assistants, some back office, and some front office. So everybody was kind of represented from our side. And then we tried to recruit patients who kind of accurately represented the demographics of our patient population. A lot of people might be a little hesitant about the recruitment process of getting patients to want to do this. But in our experience, I mean, certainly if you send out, some typed form letter, it's probably going to go in the trash. But when patients are personally invited by their trusted care team or their physician, they feel very honored and they really want to participate. So how you recruit is kind of important. If you outsource that, it won't be well received. But if you're in a room with a patient and you think, gosh, this person could bring a lot to our PFAC, that personal invitation kind of goes a long way. So I think patients are honored when their trusted provider invites them to be part of the council. And I think this is a way in which rural communities or small practices, little practices, have kind of an advantage. Like in our town, we're very small, so we engage our patients. We have patient engagement in every walk of life. Our patients are our kids' teachers, the postman, the kid who changes my oil. We sit together with the patients because our kids are on the same basketball team or whatever. So we're already kind of well engaged in that way, but a PFAC makes it more of a structured, formal entity to get work done. And I think in a small community, we're lucky in that the healthcare provider and clinic often is a cherished asset to the community in almost a familial way. there's kind of a mutual investment already there that goes beyond just the healthcare element, I think. Patients are excited to contribute to improving their health, the health of the practice and the health of the community. I think solo doc practices or small practices are uniquely able to capitalize on this asset too when we compare to like a massive health system, you know, a group of 25 docs in a clinic. When you're a small practice, I think you can capitalize on that personal touch even more when it comes to patient-family engagement. I think patients feel a special sense of connectedness to their provider, and they're not just a number in a big system. They have a strong sense of belonging and a bond to their doc and their office. And I think providers and staff feel that same way when you're in a small clinic. I guess maybe the same way as you feel a stronger connection to your local mom pop shop for a gift, or you know, dining at the local restaurant, as opposed to the kind of connection you feel when you go to Nordstrom's or In-N-Out Burger, right? Both very valuable things to the provision of healthcare, but that bond is really special, I think. And sometimes I think there's a cultural element that you can capitalize on too, to create that bond and that buy-in with patients and let them want to join your PFAC. I know in my community, I have quite a few elderly first-generation Italians in our small town, and they were not keen at all on having some young female doc with a nose ring to come replace their guy who retired. But when they realized they have a little of Italian heritage, and like my dad, I move my hands around a lot when I talk, that they immediately liked me. I was theirs, they were mine, and now they have more of a personal buy-in to me, and they're excited to help our practice in a way that before I think they weren't very interested in. So how our PFAC works, we have meetings every 2 months. We started out going monthly, and then we spaced it out to every 2 months. We get together in a community meeting space that we get to use for free. We commit to respecting their time, so 5:30 to 7. We are committed to working around Monday Night Football. We never meet when the Broncos play on Monday. We always have food, and sometimes we'll have childcare if we need to, depending on who's on the council during that time. So our Patient Family Advisory Council, during the time that we've been working on projects so far, they've helped us identify a few challenges in our practice relating to patient safety, which has a lot of different meanings, but a lot with our communications to patients and the patient experience. A really fun exercise, might sound silly, but is actually incredibly enlightening, was the walkabout, where 4 of our patients came and followed a mock patient through the entire patient experience. I think that's kind of weird. They're patients, they do this all the time. But to stand back with their notepad and write down their observations of the patient experience, everything from parking, signage, ease of getting in the building, ambient noise, efficiency of the paperwork, everything from soup to nuts of the whole thing. And they brought us a lot of interesting feedback. They also got to take a little bit of time to notice the chaos and the demands of our staff on the back end, and what they do every day, all day, and had a brand new appreciation for the incredibly difficult job that our office staff and our medical assistants do on the other side of the coin day to day, and that helped them, you know, creatively brainstorm some ideas and solutions for our efficiency on the back end too. So I think our next PFAC walkabout will be, I think, in May, sometime this spring. So we're going to do another one because everybody benefited quite a bit from the first one. This slide articulates a little bit the way that our PFAC members feel about the work that they're doing. Helping patient members take ownership in their personal health care and take ownership of the health of the community is pretty rewarding. I will point out that patient and family engagement has many faces. So you can do surveys, that is patient engagement. A PFAC council is a way to engage patients. Sometimes patient and family engagement can take the shape of engaging the community resources and the community customers that you serve as well, whether that's, like in our community we have StarPoint, which is an organization for differently abled adults or adults with disabilities. And so engaging that particular population as a structured unit and how we can serve them as a unit. So it's still patient-caregiver engagement more on a different level, but there are a lot of ways to do it. I think you guys are all starting to feel the culture shift of patient engagement in the room. So the patient engagement element in the clinical exam room looks a little bit different in that we're, co-designing the care plan with the parent. We're moving away from that culture, the paternalistic culture, the physician says do this and you just do what you're told. Instead, we're building a team and co-designing the care plan with the patient and their parents. And so I think you guys probably do a lot of that already, but that's patient-family engagement in a really beautiful way. Some clinicians that I've learned from and I'm trying to learn more from do a really good job of patient engagement with sharing their screen. So just the act of turning your computer to the mom and say, here, look at your record. This is what we're typing here. That's what you said, right? Okay, so right here we're gonna put that your child did not get her Hep B shot at the hospital. So kind of allowing them to see that screen breaks down that wall that we're behind, breaks down that barrier, and there's just this like a new element of patient engagement, trust, and partnership. And so patient engagement can be so many different things, and I think this is an example of ways that you're probably already doing it in some way or another, and it makes it seem less scary because there's a lot of models to integrate it. So transformation is a team sport, without a doubt. So number one, you need a point guard to drive the team forward. Number two, you need team members that are on board with the game plan, and you need to take timeouts and huddles and huddle together to decide on the next play. Number three, you have to watch game film sometimes and learn from best practices, learn from other teams and their strategies. Number four, you have to run drills because practice and persistence is critical to performing. We also continue to learn on the fly and improve as you go along. Number five, you have to remember who you are playing for and why you are playing at all. And number six, we can't forget importance of celebrating victories, the little ones and the big ones, all along the way to keep that momentum for your staff and the encouragement going. And that is all.
Thank you. I am so flattered. It's the first time in my life that I'm being called faculty. And bear with me when I tell you what we've done in Pediatrics in Paradise over the last 10 months. We're a small pediatric practice, private practice based in South Bay. We have two offices, one in National City and one in Otay Ranch, Chula Vista. We have 5 providers, 2 board-certified pediatricians, and 3 mid-levels. How this all started? We've been a private practice for about 10 years, and in, 2010, I sat down to write my goals for the next 12 months, and I wrote down, I want to have clinical guidelines. I want to streamline the way we practice. Because if one word can describe our practice, is diverse. And you'll see what I mean when I show you our data. So the clinical guidelines never came up because you know how hard it is to write clinical guidelines, implement them, change the way we providers see them. However, last summer, Michelle showed up in our office. Where is Michelle? She's gone. Okay, but she showed up in our office with a binder filled to overflowing with clinical guidelines. And I thought, yes, this is what I want, clinical guidelines, all for me. And I said yes, and I jumped into it, but I had no idea what I was getting into. So that's how we started, not knowing anything. At the same time, I was doing my MOC for my board certification, so you know what that means, quality improvement process. And I was being faced with undertaking the PCMH transformation process as well, which was a crazy idea I had, because why do I need to do that? After all, I'm a private practice. That's not what private practices do. So that's how we started, and guess what I discovered? And I tell you, that was the aha moment when I discovered that I didn't know anything about my own practice. You have to fill out this questionnaire, practice assessment questionnaire, and first I didn't understand half of the questions, and then I didn't know the rest of the answers. It was such a bad moment. It wasn't an aha moment. It was like, aha moment. I don't know any of this. How am I going to start this transformation? Anyway, the best way to do it was to pull a report. And the report I pulled was a lab tracking report. Labs are easy to track, right? Labs, referrals, they're attached to CPT codes. I push some sort of a send button in my EMR, and I got pages and pages and pages and pages of labs and reports. And I tell you what, when I look at all these pages, it didn't seem like anything I wanted to know. But I started to take form, and I'm going to show you that form in a beautiful diagram. Thank you for helping with the diagrams. Why did we get the data? Well, it was easy to pull out of the EMR, and it seemed like it would have some value to us. So this is what I found out. And let me tell you, it's busy, but it's meaningful. Any one of these columns, the colorful columns, are the providers. We have 5 providers, 5 different columns. And here you'll see the labs we do for obesity screening. Now you can tell we're diverse, very, very diverse. On one side, you have sort of a mad scientist doctor who is looking for something. This doctor is ordering labs. I mean, absolutely. On this other side, you have a rebel without a cause doctor who is never going to order a lab because everybody's healthy until proven otherwise. So we had a practice that was all over the place, all over the place. And the numbers were astonishing. Really, our MAs were on the phone every week. Have you gone to the lab? Have you gone to the lab? And the families finally said, please stop calling. We're not going to the lab. Okay? So, yeah, it was a real thing. It was life in National City. We don't want to get CMPs. Our CMPs were too high. Our C-peptides were too high. What the heck? Why do we need that? Anyway, these were our referrals. Again, behind every referral, there is a story. And that's why quality improvement is important. I want to listen to that. Because I'm the doctor that in the committee meeting is wiggling around when they present data, because it's just like, who cares anyway? There are stories here. There are stories that are super important. And I look at these, and I look at where is these, and I said, what's going on with us? Why are we sending people to ortho? What's our story behind? Well, it took me a while, but I sat down and I looked through the EMR. Thank goodness for electronic medical records. It's the best thing in the world. Slow me down, but I know what's going on. And I went through those consultations, and I found out the story behind that column. And it's fascinating. There are physicians who attract sicker patients. Definitely. I'm not one of those. I work with healthy newborns, so naturally my referral story is different than somebody else's. In any case, we found a lot of information, and that we were able then to sit down among the 5 of us, our little family of providers, and come up with some ideas of how to change this. So what did we do? If I fall, please pick me up. We redesigned our plan of care for patients with obesity and overweight. We were ordering way too many labs. Nobody was going to the lab, okay? We reviewed the guidelines for orthopedic referral for scoliosis. We bought $50 scoliometers. Every provider has one in the pocket. Hey, no more referrals until they're like this. Okay. And implemented the guidelines for acne. When a teenager comes with acne and the mom says, I want a referral for a dermatologist now, it's very hard to change that around. So we empowered ourselves with those guidelines. They're very useful. How do we help ourselves? We embedded our guidelines on pre-clicks. Basically, we don't need to think anymore what we're doing. It's there in front of our eyes. And I didn't do this beautiful work. It was done by my beautiful nurse practitioner, Julie, who's great for our team, but she helped a lot with all of this work. And yeah, it's right there for us to do and to see and to follow. We changed how we screen patients with obesity. No more CMPs. Sorry, you gotta beg for a CMP now. You're not gonna get it in our practice, but we target the labs that we feel are gonna give us the most feedback. And this is our pre-click for, one of the categories of obesity, and there it is, liver enzymes, glucose, lipid panel, and nutritionist referral. Why nutritionist referral? Because we realized that really where the most important part of the management of obesity lies is in the referral. The referral to nutritionist or the nutritional counseling is the most important part. That's where change happens. And our patients are not going to the nutritionist because they had access issues, cultural barriers. What did we do? We brought a nutritionist to our practice, half a day on Tuesday afternoon under my supervision. Our patients now are getting the counseling they need. We drop the labs and they drop the pounds. That's basically what we want to do. Okay, before and after. Now 5 months more of data. This is after we implemented the changes. And look at our columns. I mean, this is beautiful. Look, you like it? I like it too. Everybody's so much happier. Patients, hey, if you save them from getting draw, they're happy. Moms don't need to drive to the lab. MAs don't need to call to get those labs back in. And basically, yeah, we're targeting people that are a little bit sicker, and we're getting perhaps more positive results. And these are our referrals. We still have referrals. That's what we need to do. If we didn't do referrals, we wouldn't be practicing medicine right. And everybody's more or less in their comfort zone now. There's always the one that perhaps sees less patients, and that's me, because I'm counting them. But it's really a great feeling of accomplishment. We got the change we were seeking. I haven't heard complaints from the MAs and the referral coordinators. They're happily dealing with their job, and families are being taken care. This is a different way to look at it. Here, I just simply added all the providers in one column for CMP and every other lab, and that's the before and after. And this is pretty striking, and it's a little bit easier to see. You don't see our diversity, but you really see our change. And we're really committed to keep this going. I want this to be sustainable, and I think my entire team has bought into this new way of looking at things. We don't want to miss anybody sick, by the way. If they need a lab, they get the lab. And these are the referrals. And the same thing here. If they need a referral, by all means, they're going to get that referral. So that was our QI. Let me tell you, that's me and my sexy manager, Irma. And what you see behind us is what I did to undertake the PCMH transformation. By the way, we are not yet PCMH certified, but I want to be, and I will be. Right behind us are the 6 modules, 27 elements, and God only knows how many factors of PCMH certification. My brain could not grasp the extent of this work. It's really huge, and for a practice of 5 providers and 15 staff team members, this was pretty huge. But we are doing it. We are doing this. We have daily huddle meetings, weekly PCMH team meetings, monthly provider and staff meetings. I came into this thinking, I hate meetings. I cannot have yet another meeting. Look at the number of meetings we're having. They're paying off. They're making us a completely different practice. Our challenges, learning a new language, making time to understand the process. It's not easy to understand when you just come from a private practice perspective. By the way, I've been in practice for 30 years. I was the doctor that walked into the room with a prescription pad and deliver amoxicillin to my kids with otitis media. And this is a real different setup. Coming up with new strategies, communicating new processes to the rest of the team, making change happen, measuring results, and achieving certification. We will achieve certification. This is our weekly team, the PCMH team. The first time we met, and I handed them the modules with the 27 elements and the whatever, hundreds of factors. They were mute, blind, deaf, and like this. And I couldn't extract a word out of these girls. Now, I have to set a timer. And it's true, because this has to end when it's time for my lunch. So, and they go, but doctor, we haven't talked about these, but we need to discuss that. It's amazing the energy that these people bring into the process, and it really has changed our experience as a practice. What have we accomplished? Well, there's more items than that, but basically, we have really transformed. And I'm of the belief that if you don't transform, you died. You really do. We are in a climate in healthcare that you have to stay with what's happening now. And this is what's happening now. I'm not going to brag about this, but I feel so proud of it. So very proud. We have done a patient satisfaction survey. You could see our 2 locations are the light blue and the orange, and the combined is the purple up front. We score really, really high. And this is our wait phone time compared with 2 other practices. We answer the phone because people don't want to talk with a machine. Our new perspective, I believe we have moved from physician-centered or practice-centered to patient-centered. It's very, very obvious. Things are now done for the sake of patient care. These are the 3 aims, the 3 pillars, which are improving patient health, enhancing patient experience, and reducing cost. And I know there is a 4th one, and I added down there, and that is improving provider healthcare team satisfaction. We are so empowered. Our team is vibrant, is enthused. We are together, we're unified, and we're really moving forward. So I am so excited that I was able to present this for you. It's been a pleasure, and I thank you very much.
this is neighborhood healthcare. We're scattered all over the place. East County, Escondido is kind of the mothership, and up into Temecula, Menifee, and Hemet. We're a federally qualified health center, and those are the stats. We have about 21,000 kiddos that we take care of. And we have 3 dental sites, mostly doing pediatric dentistry. And we have behavioral health embedded in all of our sites. So some of our environmental factors, if you're not familiar with federally qualified health centers, is we're obligated to take any patient that comes to us. Most of our patients, like for my clinic, 99% or 200% of the federal poverty level or below, so they're pretty resource limited. More than half don't have English as a language at all or as a primary language. We have to get licensed by the Department of Healthcare Services, like a hospital, which is really fun. And we do get federal grant support, and we get enhanced payment for our Medi-Cal patients, but it's only for certain visits. We get paid for face-to-face visits with a physician, a nurse practitioner or PA, a PhD psychologist, and LCSW, and we're supposed to get MFT payment starting this year, but Jerry Brown pulled it back because the state has a budget deficit, so we can't do that. And almost all of our patients in San Diego County and all of our patients in Riverside County are all on some HMO. And we have some unique sites. Our Palma Valley site is a double-wide trailer. So although we have a lot of patients, all of our sites aren't that big. And we have some like rural small sites too. And we still have, and everybody forgets about these folks after the Affordable Care Act, but we still have 8 to 10% of our patients are undocumented and unfundable at this point. So, and everybody assumes everybody has insurance now, and that's not the case. So when Dominique came to us and asked us to participate in this project, I said, well, first of all, I found it very hard to say no to Dominique. She's so energetic and excited about the project. How can you say no? So I said, okay, what's it all about? And it aligned a lot with what we're already doing at Neighborhood Healthcare, and almost used some of the same words we use internally as far as using data to improve quality. So I thought, well, this would be, we had been looking for stuff to do on the pediatric side. A lot of our quality improvement efforts have been on the adult side. So we wanted something for our pediatricians and family physicians to do. So where we fall in the whole scheme of things here is the way this is all set up under TCPi. We're in the other category. So we're one of the other people. Ken Morris's clinic was North County Health Services, and I think we kind of snuck in with them or under them somehow. I don't know, I don't exactly understand, but we're in there. So here are the areas that TCPi presented to us as what we should be interested in when we participate in this project. And these were some of the very things we were talking about internally already, like bronchiolitis. Should we be treating bronchiolitis with steroids or antibiotics? Should we be ordering chest x-rays on our coughing little kiddies? And how many of our headache kids need a neurology referral and a CT scan? How often are we referring our acne patients to dermatology? So as a family physician, is there any dermatologists in here? I feel like if I'm sending a patient to a dermatologist, I'm a total failure as a family doctor. You know, I never send anybody to because I can take it off, I can treat it. I mean, every once in a while. So especially acne, you know, acne should be bread and butter. But some of our pediatricians really don't. They're not that comfortable with adolescents, and they like dump them on the family docs, and we love them because our pediatricians think the adolescents are complicated, and the family docs think the adolescents are the easiest ones we have because they're not class 4 CHF and stage renal disease with shortness of breath. So these are the TCPi measures, and they really align with what we were wanting to do quality-wise anyways. And when Dominique came to us with this, and Tom said, this is what we want to do. We want to use data to find out where we are and to improve our quality and to reduce utilization and to reduce avoidable unnecessary care. It was like, oh yeah, we're all about that, so let's do it. So here's where we're at with our measures right now. And I just updated these slides last night. Oh, these are the updated slides. Good, thank you, you got them in there. That was awesome. Because I wanted to look at our numbers yesterday, like Friday evening. And so I sent updated data. This is our up-to-the-minute data as of yesterday. So our acne referral rate is about 7% now. And that one didn't change from last week when I looked at it. Our headache referral, and these are early numbers and they haven't really been fully validated, but this is where I think where we are. And it's using the same techniques that we've been using on all of our other data to this point. That's usually right, so I think it's right. Our headache referral rate's around 14%. Our headache imaging rate's around 8%. Our pneumonia imaging rate's around 11%. And our bronchiolitis rate is 33%. Oh, maybe these aren't, yeah, these are not the updated slides. So they're actually a little lower than this, but that's okay. So that's where we are. So where do we start on this quality improvement track? So I see a lot of people in here that probably remember medical records looking like that, or looking in your office looking like that, and trying to find quality information in paper charts was like looking for the needle in the haystack, and most of those charts were in the black hole somewhere. Like where was it? So we've gone from that. We put our EMR in, which is eClinicalWorks, in 2010, and so we've gone from looking like that to being able to produce reports with real-time data. It takes me 3 clicks to get to this graph, and I can run that for neighborhood healthcare. I can run it for my site, or I can run it for me individually. And those are some of the adult measures that we're tracking with the rates and the denominators there. So this is, I guess, a little bit of a geek when it comes to data. When I think about, it was probably 5 or 6 years ago, I was talking to our CEO about trying to do the whole EMR thing, really. Because people didn't really want to do it, and there wasn't really, we knew we were going to have to do it. Couldn't really pinpoint a good return on investment. It was going to cost us millions of dollars. So, but you could tell that the value-based payment schema was coming down the line. And so, when I thought about it, I told our CEO, if we're a factory, what are we making? Right now, we're making healthy, happy patients. We're going to have another product that we have to turn out as one of our key products, a healthy, happy patient and data. Because there are going to be people that need our data, that want our data, that have to have our data, and that's turning out to be the case. So when we did the contract for our first and only EMR, not that it's the best because it really sucks. Oh, I shouldn't say that on a video. But this one we're using, and we have access to data. But in our contract, we own the data. And that has turned out to be invaluable to us to being able to use the data later on. So contractually we own the data, and when we first started trying to pull the data out of our EMR vendor said, no, that's proprietary. It's like we're going to steal their code and go write our own EMR. No, we just want the data. So that's allowed us to get the data. So after an initial battle with them, we were able to get the data out. And that's been key to us. And our mantra has been get the right data to the right people at the right time, in the right format that they can read, and have it hopefully be actionable, something they can do something with when they need it. And so we've developed QMs, committees, and all of that. We had already done the 2MA thing and patient flow redesign, and so we were the MAs were like robust MAs doing a lot of other stuff. So we've added tons of stuff onto our MAs, and I feel bad for our MAs sometimes, so much that they're doing now. But we had the same experience that they're empowered, they're interested in their job, they're not just vitaling a patient and throwing them in the room and telling me good luck. So because they're in there with me, so that's been good. We've been using registries a lot. We've been doing the huddles, and we use our data in our huddles. It's an integral part of our huddles. We have some QM committees, and one of the things we did there is we split out. We found that our clinicians on the QM committee were really not too enthusiastic about the meeting, because the meeting would end up, if it was an hour and a half or an hour meeting, we'd get to the last 5 minutes before we could actually tackle some clinical stuff. Because it was all operational stuff. The patients are waiting too long in the waiting room, they can't get through on the phones, this box isn't getting checked to satisfy that report, and we never really got to clinical quality improvements. We actually split them out into clinical quality and administrative quality, and so all the operational quality improvement is done mostly by operational folks with a few clinicians, and then the clinical quality is clinical people, and that's our clinical quality committee there with all of our clinical team leaders. We have a population health department, and that's the leader of the population health department, who is an RN, and some of our care coordinators, and one of our data people is on that committee as well. So, because there's always a question like, why is this report not showing what we think is supposed to be showing, how to track the data, where is the data being gathered? So that data person, having some of the data team people on our clinical quality committee has been important to us. Clinical practice guidelines. So this is, we got these awesome laminated clinical practice guidelines from TCPi. They've been so helpful in a way. And I thought, well, last week when I was putting the slide set together, I was like, where are mine? Well, the upper left-hand corner, that's a stack of crap on my floor, and my TCPi guidelines are in the middle. I'm horrible. So I thought, okay, I'll go to our pediatric medical director, surely his guidelines. His are, this one right here. His are above his pain scale, and his moldy coffee, and it's in a cubby above his desk with a bunch of other stuff. And so I thought, well, maybe, the nurse practitioners are better about following guidelines and stuff. So I went to our best pediatric nurse practitioner's desk, and hers are like shoved in between Nelson and some other stuff up in her hand cream. So, and they're not in the exam rooms, which is where you need them, right, when you're making those decisions. So the next thing was, Blanca, I loved how you've embedded, oh, there you are, how you embedded it. We can't do that in our ECW doesn't allow that. So we're working on, with some technical help from the TCPi folks, of getting these clinical guidelines into eClinicalWorks. The only place we can figure out to put them is, if anybody has eClinicalWorks, order sets. Nobody uses the order sets though, so we're gonna have to do some cultural change, like for this diagnosis there's an order set and go to it. And the order sets help you order stuff, and the whole point is not to order stuff. So I'm still trying to figure, having X, you can't order this? I don't know. I'm still not trying to figure out. So our key thing that we've done is we have one of our doctors is a programmer, just some basic SQL programming, and so he created this alerts app that runs in front of our EMR. So this is a screenshot of our EMR, test patient, no HIPAA violation. And test patient data, so that's why it's all red. So this is our ECW alerts app. And what it does, when we're huddling, as soon as we open the EMR, there's no separate sign, and this just pops up, and it runs down in the corner. And we're all conditioned now that as we're looking at the EMR, if we see something red down in the corner of II, it bugs us. It annoys us, and we want to make that red go away. So the red shows the things that we're looking for, and it's real-time data. It tells you when it was updated. Seconds ago is usually what it says. Sometimes it says minutes ago, or the latest it ever says is last night. So it's pulling real-time data from our EMR, and it tells us if there's things that the patient is missing, like alcohol screening, drug screening, if they had a test and it was out of range that we set, like their last blood pressure was too high, it'll turn red. It calculates their CVD risk based on their actual risk factors and their cholesterol results. It tells us what immunizations are due. It tells us if we're due for other lab tests, alcohol or drug screening. We just added food insecurity questionnaire, and these are most of these things are active, and the reason that's a blue hyperlink is if that were red, meaning they hadn't had the food insecurity questionnaire done in the last year, we could click that and it would drop in the food insecurity questions into that progress note and then satisfy that alert. So we're trying to do things like that that are, there are off-the-shelf systems that will do the same thing, but it's separate login and a separate system, and how often does it collect the data from your EMR? So we're trying to do this in real time and make it practical and handy, make it easy for the doctors and MAs to do the right thing. Also, with 3 clicks of that little wrench there, it gets us to our registry. So if I don't believe something, or if I'm seeing my own stats, I can get the patient list of my patients that need that service or whatever, and I'll show you that too. TCPi principles include some quality improvement techniques and ideas, and this is stuff we've been doing for a while. In the PDSA cycle, I was introduced to that when I went from private practice to neighborhood healthcare. A lot of the FQHCs have been doing PDSA cycles for a number of years. Tracking and reporting, this is, so what we've done is we built TCPi into, this is that, when you click the wrench, 2 clicks gets you to this screen, and then the 3rd click is any number of reports, and TCPi is now one of them. This is our overall kind of adult quality report, and some of our metrics like colorectal cancer screening, breast cancer screening, cervical cancer screening, diabetes blood pressure control, diabetes control, Pneumovax, glucose diabetes screening, and people on atypical antipsychotics and things like that. And that's organization-wide, and you can do by your site and by yourself. We do some co-opetition. So this is the rank score of all providers. You can see this list is about, I'd like to say it was 1,000 long, and then I would be number 14 of 1,000, but I'm number 14 of like 40. So, and we go up and down. So this is a Z-score. So like if you've had bone mineral density testing, you know that your score is based on versus the mean for your age group. So this is the mean for neighborhood healthcare, your Z-score versus the neighborhood healthcare mean. So you can actually be low on the rank list, but be meeting all your goals, but you're just not as good as your buddies. So, so everybody's like working their way, and people move up and down on this on a daily basis too. I looked at this last night and I didn't change this one because I'm number 22. And that was just from last week. I dropped from 14 to 22, so I better step my game up. And we're starting to look at disparities. So we thought, you know, is language do we treat our Spanish-speaking patients worse than our English-speaking patients? Do we treat our patients with serious mental illness worse, or do they have worse outcomes? And is there some disparity between insurance status if they're uninsured or insured? And for the most part, we seem to discriminate against English-speaking people because they're like the lowest score. Some of our lakeside patients accuse us, because that's where like a lot of the John Birch Society people live, and they accuse us of reverse discrimination all the time. So maybe they're right. You know, the language doesn't seem, we have like on diabetes, the score is the same. Insurance status does seem to matter. And when our board looked at this, and our board is our board of directors is our patients. When they look at this, they say, well, what's the barrier? And part of it is they can't afford the A1C test, so the board says, give it to them for free. So we're eating the cost of A1C tests now. And so I'm hopefully that'll go up. We can do, this is acne referrals to dermatology, so we can scope out who's doing all these referrals, like which site it is, and by the provider. And if we decide if we want to make the most impact, having a heat map is helpful. Like who should we target? Who's the 1 or 2 or 3 people that are really generating all the referrals? So we have this heat map. So Mitchell, whose guidelines are in her bookshelf next to her hand cream, and Nelson, she generated 11, who's an awesome NP, by the way. Like, I learn stuff from her all the time. She's generated 11 referrals, but she also sees a ton of patients. So maybe it's not a rate, it's a raw number. But if we want to reduce some of the numbers, we're going to look at Mitchell, Schmidt, and Lynn first, and maybe Strazicic and Chow. Those are also our highest volume pediatric providers, so they might be totally appropriate referral, but it gives you a place to drill down on. And then we can generate, we have the whole population health department that can use the registry to generate patient lists to do stuff with. And when we generate a list, like this was a search for breast cancer screening, we don't want to call them 8 different times for 8 different things that they need, so it tells us they're due for breast cancer screening, but they're also due for colon cancer screening. They have pre-diabetes and might need a follow-up for that. And we gave them a fit test for colorectal cancer screening, and we don't have it back yet. So, so when they call, they get to address all of those things, and then there's notes called. Murray Cruz called her, that's one of our care coordinators, on 2/1/2017 at 8:47 a.m., mailed the fit test, telephone encounter created, and I don't know what was in that, but it probably is, you know, get these tests done and come in. This is not without expense. So this is our population health department who does the behind the work scenes of calling patients when they're not in the office already. We have a budget of about 50 million, and this number is now about 1.5 million. We're saving somebody buku bucks downstream, some health plan or the state or some hospital whose unfunded admission we're preventing. But it's all, at this point, because we only get paid on a face-to-face visit with the doctor, all this other activity is unfunded. We do have some pay for performance dollars, but they're unpredictable and variable. So this past year, we probably profited on all of these activities, but many years we haven't, and I have no idea what's going to happen in 2017. These are my 2 MAs and my population health person with whom I share with other people, and that's Loretta's one of our data geeks, who we never even had a data geek 3 years ago. So sometimes, you know, it's a tough climb to the top of the mountain, but it can be worth it for the view once you get there. So this is our reports. I think on this slide, I think the one thing approach that we've taken, that I think the smaller you are, the harder it is, but taking that investment philosophy of we're going to spend a bunch of money and hire staff and retrain people, and we're not really sure what the payoff is, but it's the right thing to do for the patients. The patient's quality and satisfaction is going to be better, and we know we're going to need to do this stuff in the future just because of the trends of value-based payment and things like that. So let's go ahead and do it while the stakes are low and do it now. So I've been fortunate that my CEO and our board of directors does have that philosophy, and has allowed us to do some of this stuff. So, thank you.
Thank you so much for the kind introductions. Tom, thank you so much for inviting us over to this wonderful venue. I'm glad to see all these, some of the familiar faces who are here to support us in this endeavor. And thank you so much to all the wonderful staff here. And of course, thank you for feeding us too.
Always important.
I would like to be upfront in thanking Veronica and the RCPMS team for all that they do for our practice. CPCMG is a group of doctors and providers, and RCPMS is basically everything else, everybody else in the clinic. And without them, we're not able to do anything. And Veronica has been a tireless patient advocate. I've had the distinct privilege to work with her for more than 2 years, and basically this project is like her baby, and I'm here to, I had the fortune to support her in this. So in that vein, we'll go ahead and start our presentation.
And like I've always said, it's a team effort. RCPMS and CPCMG. So our clinic providers were concerned that our patients were not returning for routine well child checks, and therefore they were falling behind on vaccines. And so it was important to our providers to be able to monitor the patient's growth and development in the first years of life.
So this HEDIS measure evaluates practices based on the percent of children who have had at least 6 out of these 7 well visits from between birth and 15 months of age. And in order for kids to be counted, they have to be seen in the office by 31 days of age.
So our baseline, our clinic baseline for the calendar year in 2015, in a study group of 481 patients, only 364 of them returned for 6 or more well child checks prior to the age of 15 months. We really wanted to get closer to the group average of 83.9, so we set our goal to be at 80%. Dr. Akashi and I met with the staff and providers, and we discussed all the factors contributing to why our patients were not returning for the recommended well child checks. We were encountered with several issues, and our staff and providers were very motivated in improving this metric.
Some of the factors involved provider availability, and during this, prior to this period, there was one provider who was off on family medical leave, and the other factor was the limited number of late afternoon well visits, which tend to be the ones booked pretty well in advance.
So based on staff, provider, and patient feedback, some of the issues that were brought to our attention were our phone wait times, appointment no-shows, and scheduling opportunities. Back to our phone wait times, our patients were not able to get through to schedule appointments because of excessive phone wait times, and we had limited utilization of MyChart, which allows patients to schedule their own appointments online. We were not confirming appointments consistently on a daily basis, and it was because we had staff out on LOA or because we had open positions. We were also not scheduling future well child check appointments at every visit, and we were not working our no-show list. So some of our interventions are as follows. For our phone wait times, our staff was instructed to monitor the phone queues and help and assist in answering phone calls anytime the queue had 3 or more calls. For our limited MyChart utilization, the staff recognized the need to schedule, to offer MyChart to all patients, and if a patient declined, then they were instructed to document in the appointment notes and in the rooming notes. It is my job to consistently monitor the phone queues and the MyChart activations and coach in the moment. One of the major changes that we are looking forward to and we're real excited about is our regional scheduling. And what this is it's a group of PSRs, or patient service representatives, that focus mainly on answering phones. And this is going to help minimize the phone wait times for our patients. We were also, our appointments are being confirmed consistently on a daily basis.
From a provider standpoint, during each of our encounters with our patients, whether it's well visits or sick visits, we have been more conscientious about trying to remind their families to schedule the next appointment on the way out. And that, of course, includes the sick visits. If we notice that there's an infant who is very overdue on their well visits and their vaccines, we try to gently remind the families and help them find the best time for them to bring their child in. And if we need to communicate some detailed instructions about scheduling the appointment, we can use our EMR functions of the checkout note workflow that allows the scheduler to look at the instructions and best accommodate the family.
So this really is a team effort, and we ask that all of our staff be involved. Our MAs are reminding the patients and the families to schedule their well child check at the time of checkout. Our PSRs are reviewing the appointment desk in order to identify missed appointments. and also at the time of checking or scheduling sick visits. And sorry. So when it is, we understand the stress that is brought onto, that can be brought onto our patients when, or to the parents when their child is being seen because they're ill or because they're being vaccinated. And so in some instances, if the provider feels that the family is running short on time, one of the things that the provider will do is either ask myself or another staff member to come into the room and schedule the next well child check for the family. And by doing this, we are utilizing all of our resources and ensuring patient satisfaction. We are also consistently working the no-show list according to RCPMS policy.
With regards to provider availability, the provider who was on family medical leave did add back a session, allowing us to accommodate more families. And with regards to the unfavorable hours for the families, we're trying to brainstorm ideas to possibly add some later well visits towards the end of the sessions or the day. We have also been fortunate to have a nurse practitioner join our team to help us see all the families.
So I'm sure you guys are all you guys are all thinking, wow, this is a whole lot of work to have to give to the staff. And in reality, it wasn't. We just didn't have a consistent process in place. And by the staff, the RCPMS staff following policy consistently, and providing auditing and we're ensuring support and success.
So going back to the baseline data, we started off at 75.7%, and our goal was to reach 80%, which was closer to the group average. And after the intervention period, we did improve to 84.6%. So we were very happy about that.
We were. So not only did we surpass our goal and the group average, but we had additional gains. We decreased our no-show rate by 8% and increased our visits by 862 visits, which gave us a revenue of $86,000. We also increased our MyChart activations by 3.5% since March of 2016 by activating 960 patients. Some of the things that we did is customize the daily appointment report to identify all patients that were not registered, and the staff was taking advantage of that and offering MyChart to all of the patients. So some of our staff and provider comments, this is quoted by one of our PSRs, Jennifer. In the beginning, it was difficult to manage all the tests, especially when we are busy with patients. But as we did this consistently, we each developed a rhythm that worked for each of us. Now I feel we have become more efficient.
And one of our providers, Dr. Mario Bielostowski, said that I have noticed a big improvement in the decreased number of no-shows, as well as patients arriving on time for their appointments.
So we communicated the results to our staff and our providers, and as you guys can imagine, they were all very excited. We did celebrate with a catered lunch, raffles, and prizes for the staff. So some of our next steps is to ensure that this sticks, and we are accomplishing this by providing continuous support to the staff and the providers and maintaining their engagement. We're also looking to move the bar and adding a focus group, a patient focus group, to solicit more feedback. So we leave you with this, a famous quote by Henry Ford: "The success of teamwork. Coming together is a beginning, keeping together is progress, and working together is success." Thank you.
Thank you for inviting me to join you guys today. This has been very interesting. I actually learned a lot, and there's some stuff that we could actually take back to what we do as well. So I'm representing the Rady Children's Medical Practice Foundation today. It encompasses the pediatric subspecialists and the surgeons who work here at Children's. And the reason I'm speaking about communication in healthcare is that, as Dominique mentioned, there has been for quite a while an effort to get parents and patients to give feedback about their visits, and then we go over those data and see how we're doing. And the numbers aren't bad, they actually look good, but the needle wasn't moving, and that part was just sort of unsettling. So I'm an oncologist, and if you look at something like childhood cancer and say, well over 80% of children now diagnosed with cancer become long-term survivors. Usually when you say that, like the room applauds and everybody's happy, but my mind's like, wait a minute, almost 20% of kids are still dying? We have to do something, something's wrong, this is not okay. So when I look at the numbers for patient satisfaction and you say, oh, we've moved up to now say 72% of people say excellent. And then it's like, but wait a minute, people are leaving saying that the care wasn't excellent. Like that's somebody's leaving and it's not okay, then that's not okay with me either. They come here because they're sick, their children are sick, and then they're not leaving thinking like we did everything for them and they're just really pleased with our efforts is not what we wanted. So if the needle's moving and we're improving, then okay, we're not perfect, we're getting there, but the needle hadn't moved in a few years, and so it was concerning. So trying to understand that led to this whole endeavor that I'll begin to talk about. And we're doctors, we want to fix things. Come to us with a problem, we'll make a diagnosis, we'll come up with a treatment plan, implement it, go home, do it, come back, we'll check and see, are you doing better? That's our idea of success. They're doing better, fine. Not necessarily the way the family is looking at it though, and this is something where we have to sort of shift the way that we're thinking to say that the most important factor for many patients and their parents would be the interaction and relationship with the physician. It's kind of a given. You know what you're doing, you've been to school, you're going to use your experience and your knowledge to make a diagnosis and a treatment. That's not the standard we're trying to meet here. Do you care? Are you treating me with dignity and respect? Are you listening to me? Do you understand what my concerns are? Do you understand the hardships? That's partly how they're grading us. It's okay that we're doing a great job. They don't want us to not do that, but there's more to it than that. So if you look at how to solve this and you take it just from the point of view of the physician who's seeing patients, you're probably not getting the whole picture. So we engage the help of the Institute for Healthcare Excellence, and they have a course that can be used in the center here. But the trainers are not these Institute for Healthcare Excellence faculty who come out, it is us. We have to become the trainers. So automatically I was like, no, send somebody in who knows about this and have that person teach us. That's not the plan. So I was, in one of my roles, was given the task of sort of bringing this together. And so the first thought was I'm supposed to find 10 of our busy doctors who are going to volunteer to teach all the faculty, and this is taking more than a year because we're doing this monthly courses. I'll never get 10 people who are going to volunteer to do this. Well, we got more than 10 people who volunteered to do it, and we were able to select the ones who we thought would be the best teachers. We actually had to turn some people away. And then we all went through it's about a week-long training period. It was 3 days and then some downtime where we had to do some homework and then go back for the last couple days of training to become the trainers. Okay, then the next thing I thought was, we're never going to get all of our doctors to agree to come in and do this. So we had to make it mandatory. And surprisingly, the classes filled up. Like we set up several months of classes online, go in and register, they were filled up, and people were complaining like, I can't get into a class. Like, where did this come from? This is great. So we opened up more classes, those filled up, and people are continuing to sign up. The feedback we've gotten, having us, their colleagues who are there in the trenches during the teaching is really important. With the feedback after the classes, the doctors will say to us, I'm so glad we didn't just have to come in and get a lecture from somebody who's supposedly some expert. It's people who understand what we're going through are talking to us about ways to make it better. There's credibility in what we're saying because we've been there. Each course is 4 hours long, and it is interactive. So they're not just sitting there the whole time. There's a little bit of speaking in the beginning, and then it's breaking into small groups and doing exercises, coming back, reviewing it as a group, back into the small groups. So there were a lot of excited participants who wanted to get in there and do it. There was a smaller population but present of people who really didn't want to be there but were told to, so they showed up. And many of them, by the end, would say that when we asked them for feedback at the end of the class. I didn't really want to come, but this was really good. It opened my eyes. I'm so glad you made us do this because it was helpful. Now, there still is that little shard of people who are reluctant learners who didn't want to be there, who didn't like the class, and who wanted to just leave. That's a dwindling number of people because some of that dissatisfaction is contagious. That one or two people talking bad about it, and then everybody's going to talk bad about it, and there's not that much bad press going on about it. So people are kind of showing up with an expectation that it's going to be good. And at the end, I'll get to, and Dominique kind of already talked about it, that the speed with which we made progress really exceeded our expectations, because we were saying our expectations based on what the IHE had suggested, that it takes years to sort of move the mountain, and we actually made some progress even more quickly. So it's a 4-hour curriculum. It's designed to enhance the patient experience by making the patients and their families feel heard and understood. By having better communication, there's better safety in the care. Employee engagement and satisfaction is a very important part of this, that people are leaving happier because the experiences aren't so frustrating. And I neglected to mention in the beginning that in addition to the physicians, the staff are involved. So the people who are on the phone making the appointments before they ever come in, the people who greet them when they check in, are all going through the class. And there are trainers who are their peers who went through the training and are teaching the class to them. Decreasing adverse events is one of the goals because there's better communication, less missteps. Creating a culture of mutual respect, safety, and teamwork. Improving patient compliance. So if we are listening to them and they understand what we're talking about, we understand where there maybe need more education, they're much more likely to go home and do what we're saying that they should do, and then we will get better outcomes in the end. Back to the idea of people going home feeling happy because they've not had bad experiences all day long. There's better satisfaction with the job and less turnover. Decrease in malpractice events. It's not us and them. We're working together as a group. Hopefully restoring joy to the practice of medicine. I think I said this to somebody a while back ago. Those of us who are baby boomers are thinking we're going to retire soon, and there's a lot of us, and there's not as many of the Gen Xers and millennials out there, and they're going to be taking care of us, so they can't burn out. They need to stay in medicine. They need to be taking care of us. And then build resilience to meet the ever-changing needs of the healthcare environment. So this shows a little bit about the program. There are a little bit of didactic learning, but breaking into small groups of up to 6. So depending on how many people sign up for the course, maybe 4 to 6 people in the small groups. And it's interactive. There are role modeling. There are cases they bring in, cases that we present to them, where we play out being the doctor, being the patient, and using the skills of communication that we're learning. And it is CMA accredited, so people can get credit for having done this. And then as we move on, I will talk about all the different elements that we teach, which is mindfulness and presence, followed by active listening, information gathering, negotiating an agenda, connecting with patients and the team, and then the skill of appreciation. And connecting with what I will also describe are the pearls is an important part of that, and we'll focus a bit on what those are in a moment. So communication skills are essential. The healthcare clinician and the patient relationship is where it all begins. But in addition to that, as I said before, safety and communication among the faculty, among the physicians, among the caregivers is also important, and sometimes that's not happening. And then daily interpersonal contact. So you could take these skills home with you as well with your friends and family and increase better relationships. Now, we're talking about communication. Physicians' minds trained on show me the data, show me the science behind it. And communication becomes a bit looser than that. But there actually are data, people who have studied and documented the value of improved communication, and the strategies to improve communication are also things that are documented by data. And those improvements in communication lead to better outcomes and lead to better safety. Now, I know, at least from my vintage of having gone through medical school, there was no mention of communication in the curriculum. And we taught a class just this last Friday to our residents. They were the second and third year residents. We gave them the exact same curriculum. And several people said, oh, this is great. I remember doing this in medical school. And it's good to get a refresher course in it now that we're actually seeing patients, because then it wasn't real. And now we're actually seeing patients and it can make sense. And I thought, this is great. They already got this. And now we're doing a refresher course. And I have to say they were better than the faculty, and engaging quickly, getting what we were talking about, and soaring ahead. So teaching this is actually really something. There are books about it. There are scholarly people who've studied it, who are writing about it, and people who take courses about it. So those of us with our physician science blinders on don't realize there's all these other fields of study and that we can learn from this. So this is a great part about this course. So data. About 250,000 patient encounters during a professional lifetime. About 25% of those often being described as frustrating. And of that 25%, half of them can reach the point of being described as difficult or dysfunctional. That's a lot of time spent in difficult conversations. So making that better is essential. Now, we, and I'm going to go with my generation now, sometimes feel poorly equipped to deal with this, because as I learned on Friday, this other generation's already got it down, which is great. But we don't feel that we are well equipped to deal with it. And even if someone had, say, given me this curriculum many, many years ago, the demands placed on all of us, how many patients and how sick they are all at once, doesn't really give you the opportunity to practice all your communication skills in real time. Then there's also behavior and personalities of some patients and families that are going to strain the healthcare system. We have to accept that. We can't tell them you need to behave differently when you come here so that we can provide you better care. We have to take what we have and go from there. And then in addition to that, there are personal, social, and cultural perspectives that maybe interfere with communication is not the right term, but at least inform communication. So we have to understand those backgrounds that we bring in and that others bring in, and how to work with that to make for effective communication. So from the patient's perspective, 80% have been reported to have said that they feel the doctors are too busy to listen to their complaints. Kind of scary. 33% of inpatients say the nurses and aides were too busy to address an immediate concern. So my parents are in their late 80s. I spent a lot of time recently with them in doctors' offices and hospitals. I would say I get this now. You sit there in the hospital and you watch what's going around from the other side. People do look like they're too busy. You're hesitant to ask somebody to help you because, gosh, look at all the stuff that they're doing. And sometimes people really are too busy. They're not intentionally giving off that message, but they are. That like, I'm here and I'm moving on now because I've got other things to do. And that creates a problem. 27% say their primary care physician failed to address the main concern, and 32% said that of the subspecialist. So their main concern may not be ours. We have to understand that. My main concern as I'm looking at you is make a diagnosis. Their main concern, they have something they want to say. They need to be given time to say that. So when you look at what patients value in the healthcare, these top boxes, treating you with dignity and respect, listening carefully, easy to talk to, take concerns seriously, willing to spend enough time with you, truly care about your health, are the top ones that people scored. And those all fit into a box that could be, I think this requires another click, could be summarized as communication. That doesn't mean that as you go down the list, they don't care anymore, has good medical judgment. Of course they care, but that's a given to them. Like, you know what you're doing, I want something else in addition to that. So communication is really what people are saying they want when you ask them. And this slide provides similar information, and that having someone who listens is at the top of the list. This is Joint Commission data about sentinel events and what the triggers were for it. And so human factors go across the top, and perhaps we can't do much about that. But if you go down, communication is a really important theme, and that comes into this idea that we're passing information about patients to each other, we're pulling in consultants and other people, and how we are communicating amongst ourselves has a lot to do with errors or sentinel events that may happen. So what's the evidence for better communication? Increase in patient satisfaction, however one would measure that. Families and patients adhering to treatment plans. More appropriate medical decisions based on what patients are complaining about and what they want to have addressed. Decrease in malpractice claims if communication is better, then there's more of a sense of teamwork and working together. And then, of course, the all-important physician and allied health personnel feeling some job satisfaction and some joy in what they're doing. All right, so the course goes over this circle, and it starts with presence, then it moves on to listening, information gathering, joint agenda setting, connecting with the pearls, and I'll explain what that acronym is in a moment, and then appreciation. So I'm just going to give a little brief description of each of those. The course focuses a little bit in much more detail on each of these different topics. So presence. So this is us. This is our minds, right? When we sit down in with a patient. So we're already thinking about a whole bunch of stuff, and that doesn't leave our mind when we walk in there to see the patient. And then if you look at all these Post-it notes around, that's all the stuff we have to do. We have to get to all those things throughout the day and pull all those down and cross them off. There is some teaching that happens in the course about presence and mindfulness. And the important part would be to sort of say, stop and collect your thoughts about what you are about to do and what you need to do. So it might be a matter of just take 2 deep breaths and walk in the room. Remember, I took a class and there's stuff I need to remember and walk in the room. Maybe it's you picture yourself in Kauai or Yosemite or something. Some of the surgeons actually say before they go in to do the OR and they're washing their hands, that's the moment when they stop and get their presence. Say, what am I going in here to do with this family? Stop and think about that, rather than to walk in with the message of, okay, I've got 100 things to do and now this is one of them and I'm going to do it. I'm going to think about the other 99 while I'm doing this one. Okay, and moving on to listening. So this may sound easy, but it's not when you're so distracted. And so the excellent starting point for beginning a dialogue, attitude. So you need to be curious, not judgmental, and seeking to understand the patient's perspective. That's the starting point. It's not, I've figured out what's wrong with you and now I'm going to explain it to you. And then to get to that next point, you have to develop the skill of asking open-ended questions and then actively listen. Okay, so you ask an open-ended question, you're going to be like, I'm really busy, and if I ask an open-ended question, I could be here for the next half hour listening to all the answers. So when you interrupt that story, you're probably going to change the course of the story. They're not going to remember something. They're not going to think it's okay to go back to that point because now we moved on to something else. So you've already changed the story that you're going to get by not allowing that person at least a moment to tell the story. We start jumping to conclusions because we want to fix it, and we've gotten a few clues. I can fix it now. Don't talk anymore. Let me just fix it. Not the right way to go. And then patients and families need a period of uninhibited talking at the beginning of the visit to express their concerns. So how long is that going to take? So on the average, how long does it take a patient to complete a list of concerns when not interrupted? Feel free to jump in if you want. The answer is 1 minute. So this is Institute of Healthcare Excellence surveying and collecting data. So you can say this is not my patient population, but talking for a minute is actually a reasonable amount of time. If it's not the average, what's the longest it takes a patient to complete a list of concerns? Now, this is not the entire conversation. This is just to say, I'm going to listen to you tell me what your concerns are today, why you're here. Okay, you're not going to say, tell me everything you've ever thought about pain or something. Okay, 3 minutes for the longest one to complete that initial question of asking that. So 3 minutes isn't that long. Now you can clearly say that my patients will step outside of that, but I would challenge you to say, well, give it a try and see with that question what they actually come up with, because the average time it takes the physician to interrupt So if they only needed a minute to tell their story, and 18 seconds into it, we were already into, okay, yeah, I know, this is what I need to do, then we have changed the course of the story. So active listening is hard, but it's a skill, and to stop and just listen. And I think there are geographic variations in this, the way people communicate. I grew up here in Southern California. We tend to sit back and listen. We're a little bit calmer. In other parts of the country, it's like, and you can't stop talking. But to stop and listen is important. So moving on, and I wish I had time to go into all these with you because there's a ton of stuff that we do with this that's important. But information gathering and joint agenda setting. So the healthcare provider, the clinician, is the expert on the disease, but the patient, that person or the patient's parents, that's the person who's the expert on him or herself. So we can't just focus on what we think and what we have to say. We have to allow them to express what they have to say because they're the experts on themselves. And the focus needs to be on the patient as well as the disease. Clearly, it has to be both. By doing that, we get a better history. If we go back to the early medical school days, there's nothing more important than the history. Well, it's true. We need to get that story. It sets the stage for a better relationship. They feel, oh, this person cared enough to let me talk for a minute. That's what they're asking for. That's number one on their list. Doing it isn't that hard. And then it increases clinician satisfaction downstream. The patient's not mad. The patient's not upset. The patient's not disappointed. And most importantly, the patient at the end of the visit, when you're just getting your hand on the door to walk out, doesn't say, oh yeah, one more thing. And you sit back down and now you've got this whole other thing to do. You let them at the beginning set their agenda. Now maybe the joint agenda setting is that you say, okay, you just brought up 4 really good points. I think number 1 is the most important. And I get the sense that you're telling number 2 is what you really want to talk about today. How about if we do those 2 today? We're going to take 3 and 4 and tackle those at another visit, just so that we can do due diligence with 1 and 2 today. Okay, that maybe they wanted all 4 addressed, but they understand that 1 and 2 are going to be addressed today, 3 or 4 are coming later. You've heard them, and you sent the agenda jointly, and maybe the person can say, I don't really care about 2, you misread me, I want number 3. It's like, okay, we'll do 1 and 3 today. So the benefits of this would be that when patients believe their concerns have been heard, they're more willing to accept the recommendation. Okay, I've been heard, now you're telling me what you think, okay, I'll go try it. As opposed to they've not had their concerns heard, there's dissatisfaction. And then they go home and it's, oh, that doctor was awful. And then someone says, why do you listen to what he says anyway? And then it's not being done. Okay, moving on to connecting with the pearls. And we're not going to run out of time on this one. So we have to recognize that patients come in, the parents come in with emotions, whether anger, fear, sadness, anxiety, uncertainty. We have to respond to that. We have to acknowledge that and respond in a certain way. So the pearls stand for partnership, empathy, apology, respect, legitimization, and support. And in the course is practicing expressing these things. So partnership, it's not hard to say, okay, we're going to work on this together. When you're setting that joint agenda with them, you can say, we're going to work on this together. I would like to do this. You would like to do this. Let's get started. Giving them a sense that you have a stake in this too. It's not just me talking, and we're going to work on it together. Empathy. So I think hopefully it's true. All physicians have some innate empathy. That's how they arrived at this point. Making sure that you harness that and express it. You're feeling it, you're assuming the person knows that, but did you say or do anything that expressed the fact that you are empathetic? Now, you don't want to say, I understand exactly how you feel. Well, they could say, no, actually you don't, and they will be right. But there are ways to say certain things, and this may not work for you, or even for one particular family or another, it may not work. And if these things don't work, just to say, I can't imagine how you feel. Maybe that's enough of it, just to say, yeah, that sounds hard. I can't imagine how hard that really is. And then move on from there, rather than to just stop. I have something to say to you, and I'm going to say it. Apology. I think there was an old idea that you didn't ever apologize because that was admitting fault. Well, if you have something that you're sorry about, then you can say it. You were delayed in the room there for 30 minutes because I was with another patient. I'm sorry you had to wait. It's fine. You don't go, I'm sorry I had to wait, but you know what? I was really busy, and our medical record system is really slow, and it slows me down. Not I'm sorry, but if you feel the need to, you can say I'm sorry, and I'm sorry that you had to wait. I had a lot of really sick patients, and they're all plugged in now. I'm here for you, and you have my full attention. So there are ways to apologize and make it seem sincere, and you probably really are sorry that they had to wait. So there's nothing wrong with expressing that. Respect. So somebody comes in having done a lit search, something on the internet is wacky data, the person's organized it all and come up with all this stuff. Just no, that doesn't make any sense, let me tell you, isn't really the right approach. To acknowledge you've researched this, I can look this over for you if you'd like, let me tell you the data that I'm basing it on, being respectful in the way that you respond. And then legitimization. Anybody would be sad by this. This is just sad information, I understand that. And then moving on from there. And then support, and that sort of would be the final thing to say. I'll be here when you need me. I'll stick with this with you, just to somehow be supportive, to make people feel, okay, you hear me, you understand on some level, you're going to be supportive. And then the last skill is appreciation, and that's kind of an easy one to think about, but the skill is just to express this appreciation and think about that. So at the end of the class, we ask people to express appreciation, and it's hard. Like, what do you appreciate, either about this course or something else? And often they sit there quietly and say, no, everybody has to come up with one thing, because we don't do that. We don't stop and express appreciation, whether it's to the patient or just to ourselves. At the end of the day, what did I appreciate about what happened today? All right, so that's the course that we taught, and I have 5 minutes, so I'm going to move quickly now. So these were our data, and I blocked it out here. What is down here on the bottom, each little bar represents a specific division, and I decided not to share that with everybody. And the final one here is the Medical Practice Foundation total. So these were our data, which was about 70% or so. And then we implemented the course in August, and our data through January look like this. So we now are up to 77% of patients describing this as excellent care. Now that we have a ways to go. This isn't the stopping point, we're not done, but it was quick. Now, I'm not saying I completely can document that this is all causal, that we did this course and therefore the improvement happened, but temporally it's related, that we started this course, we haven't seen the needle move in years, and then we started the course in between August and now we have seen that change happen. I think it's significant. I hope it's continuing to be documented as we continue to survey our patients. The Institute for Healthcare Excellence, who had told us this was going to take years to happen, got back to us when they saw all this and said, you guys have done an amazing job. This is really a big accomplishment. And they are going to be giving us their 2017 Culture of Excellence Award based on this accomplishment, which will be presented at the IHE Annual Conference in Austin, Texas on June 2nd, where we are going to be the recipients of their annual award based on sort of changing the culture of the institution. And that, I think, is terrific. And I'm happy to know that a greater number of our patients and their families are leaving at the end of the visit feeling that the experience was excellent. All right, thank you.